Good morning, everyone. The Subcommittee on Health will now come to order. Let me just say that we will hear several deeply personal stories from our witnesses today, and we're grateful on behalf of all of my colleagues to have you with us. We appreciate your being here today and the testimony that each one of you are going to give. Our subcommittee has always prided itself on a tradition of respect and collegiality, and so I ask not only all the members but also the everyone that's here in the hearing room today to continue in that tradition. The chair now recognizes herself for 5 minutes for an opening statement. Nearly 50 years ago, the Supreme Court of the United States affirmed the right of every woman to make decisions about her own life, her body, and her future. Now that right is under threat by state laws restricting and banning reproductive health care and abortion care. Since 2011, states have passed more than 450 medically unnecessary restrictions on reproductive care. For example, Alaska, Kansas, Oklahoma, and Texas forced doctors to lie to their patients by having them inaccurately link abortion and breast cancer in their patient counseling. Louisiana, Texas, and Wisconsin require providers to perform medically unnecessary ultrasounds and show and describe the images to women who have already decided to have an abortion. 18 states have specific requirements for procedure rooms and corridors, as well as requiring facilities to be near and have relationships with local hospitals. These requirements do not improve patient care, but purposely set expensive standards that make it difficult for clinics to stay open. Today, 90% of our counties in our country are without a single abortion provider, and 6 states have only 1 clinic. So why is this a problem that the subcommittee should address? First, these restrictions deny women access to safe health care. Restricting abortion does not stop abortion. It makes it less safe. A nonpartisan study by the National Academies of Sciences found that the biggest threat to the quality and safety of abortion care are state regulations that create barriers to trained providers. When abortion is accessible and legal, it is extremely safe. The rate of serious complications in first trimester abortions is less than 0.05%, making abortions 40 times safer than a colonoscopy. When abortion care is restricted, women face devastating consequences. The landmark Turnaway study, a 5-year longitudinal study by researchers at UCSF, followed 1,000 women who sought but did not always obtain abortion care. The researchers found that the women who were denied health care consistently faced worse outcomes than those who received it. The women forced to carry a pregnancy were more likely to experience eclampsia and more likely to stay with abusive partners. They were 4 times more likely to be living below the poverty level. 2 women who were denied abortion care died of pregnancy-related causes. Every day, women across our country face the deeply personal decision of whether to continue a pregnancy. They should be able to make their own decisions together with their partner, their husband, their minister, their rabbi, their priest, free from political interference. The Women's Health Protection Act ensures that every American woman has equal access to comprehensive reproductive health care, no matter where they live in our country. This legislation follows in the tradition of the Voting Rights Act of 1965, where Congress safeguarded a constitutionally protected right. That's because states don't get to pick and choose what part of the Constitution to follow. When we support access to quality, affordable health care, we reduce the rate of unintended pregnancy. Today, the teen birth rate is at a record low. Total unplanned pregnancies recently hit the lowest level in 30 years. Any member who wants to reduce abortions can support public health programs proven to reduce unintended pregnancies, including increased access to no-cost contraception as provided by the Affordable Care Act, comprehensive sex education that includes medically accurate information, programs to support women facing domestic violence and sexual abuse, expanding Medicaid coverage rather than cutting it by $920 billion as the president proposed this week in his released budget. The chair now recognizes Dr. Burgess, the ranking member of the Subcommittee on Health, for his 5 minutes for an opening statement.
And I thank the chair. I do feel that today's hearing is an indication of where the Democratic Party is headed. The policy concerns surrounding abortion and the right to life are not new, but a bill such as H.R. 2975, with over 200 members of the Democratic Party in support, is in fact unprecedented. This bill before us today transcends pro-life and pro-choice issues. The question of abortion, sometimes reduced to yet another political issue, is personal for some of us. It's personal for me. My belief in the right to life has influenced my professional career for much longer than my time in Congress. Before being elected to represent the 26th District of Texas, I spent over 25 years practicing as an OB-GYN in North Texas. My medical career was rooted in my pro-life practice and the belief that all life had meaningful potential. In the span of my career in obstetrics, I delivered more than 3,000 babies. Not only did I have the joy of seeing these babies when they were delivered, but throughout my career, I witnessed great advances in technology. It's interesting, at the time that Roe v. Wade was adjudicated by the Supreme Court, sonography was itself in its infancy. It is technology that was really only available to me in the latter half of my residency at Parkland Hospital, and they've seen great strides. And yes, for those of us who've watched a baby with purposeful movements in utero, there's no question to me about the sanctity of life. While my work has changed, I now spend late nights delivering policy rather than babies. My dedication to pro-life medicine remains steadfast. Ironically, the bill is called the Women's Health Protection Act of 2019, even though if this bill became law, it would put women's health and safety at risk. The heavy-handed language that this bill uses is what places that risk by codifying that there may be no restrictions, no prohibitions on any particular abortion procedure prior to viability, may place at risk a number of women to potential harms associated with certain abortion procedures and complications such as infection, bleeding, uterine perforation, with no ability to regulate for safety purposes. Not only does the bill raise questions about the Democrats' concern for women's health and safety, it also raises questions about the regard for the United States Constitution. The Supreme Court established the viability test in Roe versus Wade in 1971. The standard says that once a baby reaches the point of viability, a state may regulate or prohibit abortions. In Justice Blackmun's opinion in Roe v. Wade, he stated that viability is usually placed at about 7 months or 28 weeks gestation, but it may occur earlier, even at 24 weeks. In 1973, a baby being born at 24 weeks had very dim chances for survival. But I will tell you, throughout my career, the youngest gestational age baby that I personally delivered was 23 weeks, and that child went on not just to survive, but to thrive without any neurologic sequelae. Last week at the State of the Union, President Trump recognized a young girl and her mother in the crowd. This youngster, Ellie Schneider, was born severely premature at 21 weeks. Ellie is now perhaps the youngest baby to survive early gestational delivery in the United States, and she's now a happy and healthy 2-year-old. So for me, it's incredible to see the medical advances saving the lives of mothers and babies. As the viability of a baby occurs earlier with the help of medical innovation, the Roe versus Wade standard inherently extends the rights of states to regulate earlier in a pregnancy term. A bill like this seeks to override and dismiss the viability standards set by the Supreme Court in the wake of medical advances that are saving babies' lives. The bill would also codify into law that access to an abortion is essential to women's health and, in fact, is contrary to one of the founding principles of our country, which is a right to life. The federal government should work to overcome the factors that lead to abortions and should support well-crafted legislative proposals that directly address these factors, but that is not this bill. I'm a physician. Most members of Congress are not. But this bill does cross a line. It's perhaps the most uncomfortable and threatening legislation that I have seen that threatens not just hospitals, doctors, but the very women patients we serve. I yield back my time.
Gentleman yields back. It's a pleasure to recognize the chairman of the full committee, Mr. Pallone, for his 5 minutes for opening statement.
Thank you, Madam Chair. Today's hearing is on legislation to protect women's access to abortion care. This legislation is necessary today because states have passed an onslaught of ideological bans and restrictions intended to interfere with women's personal medical decision-making and to severely limit women's access to abortion care. Since 2011 alone, anti-abortion state lawmakers have passed nearly 450 restrictive laws with the sole purpose of making it more difficult for women to access this care. They've passed mandatory waiting periods, requirements for multiple in-person visits, and requirements that doctors provide their patients with medically inaccurate information about the potential risks of the procedure. They've also passed ridiculous and unnecessary building requirements for abortion providers that are intended solely to shut down clinics that provide abortion services. And the result of these increasingly restrictive laws is that women all across the country are having a harder time accessing abortion care, which they have a constitutional right to obtain. Comprehensive health care means having access to affordable abortion care, which is a safe medical procedure with far fewer risks than many routine medical procedures. Repeated studies have confirmed the safety of abortion, including comprehensive findings by the National Academies of Science, Engineering, and Medicine. It is a legal and safe procedure, but ideological state legislators continue to put up roadblocks for women and providers. Today, nearly 90% of American counties are without a single abortion provider, and 6 states only have 1 abortion clinic in the entire state. The unfortunate reality in America is that your constitutionally guaranteed health care rights are now dependent upon where you live, and that's simply wrong. Sadly, we know that anti-abortion restrictions fall hardest on those who already face significant barriers to health care, and that's low-income women, women of color, LGBTQ people, young people, and people living in rural communities. At a time when we should all be working together to reduce health care disparities, we're watching states across the country actively pass legislation that increases those disparities. And their actions are putting access to care further out of reach. One particularly alarming study from the Center for Reproductive Rights and IBIS Reproductive Health found that states with more anti-abortion laws have poorer health outcomes generally for both women and children than states that have fewer restrictions. This should be alarming to all of us, especially as we're faced with an increasingly dire national maternal health crisis that we also know disproportionately impacts women of color. It's for all these reasons that we're now holding this important and timely hearing on the Women's Health Protection Act. This legislation simply ensures that patients can access and healthcare providers can provide abortion services. It prevents medically unnecessary and burdensome restrictions that single out abortion services and deny women access to care. It's long past time that we affirm women's health care rights by ensuring that they can actually utilize those rights. The Women's Health Protection Act would do just that by ensuring the constitutional right to have an abortion is a reality for all people, no matter where they live. And finally, I want to thank our witnesses for being here today. I know this can be a very personal and at times difficult conversation to have in a public setting, And I want to express my sincere thanks and appreciation for all of you for being here today and sharing your experiences and expertise with the committee. And I'd like to yield a minute and a half to Representative Schakowsky.
I thank the gentleman for yielding to me. Abortion is health care, and health care is a human right. This hearing is historic, but it's about time that the Congress has finally weighed in and said that we do support the right of women, regardless of color, of income, of state, of zip code, to have the health care that they need. This is about the women who deserve comprehensive reproductive health care, all of them. And for the first time in over 20 years, our committee is considering a proactive bill that would guarantee the constitutional right to abortion care, free from the interference of any politician who has no place in making this very personal decision. Protecting access to abortion care isn't the beginning of women having abortions, but it is the end of women dying from abortions. We will not go back. No matter what is happening in states around the country, women will go forward together to protect our rights. And I yield back.
And I yield back.
The gentleman yields back. It's a pleasure to recognize Mr. Walden, the ranking member of the full committee, for his 5 minutes of an opening statement.
Well, thank you, Madam Chair. During the State of the Union address, President Trump welcomed and spoke about Ellie Schneider. Remember, she was the little girl who was delivered at just 21 weeks gestation. The President called for policies to protect the unborn after fetal viability. Following the State of the Union, the Senate Judiciary Committee held a hearing on medical care for children born alive. Instead of considering these policies, we're regrettably convened here today to discuss yet another deceptively titled partisan bill that has no chance of becoming law or being considered by the Senate. We all know the issue of abortion is a very sensitive one. It's a painful topic for the women and men who, for whatever reason, find themselves facing the dilemma of whether or not to terminate a pregnancy and in turn a human life. Abortion is one of the most polarizing subjects in American political discourse, but even many people that consider themselves pro-choice believe some restrictions are appropriate. 7 in 10 Americans support substantial restrictions on abortion after 3 months of pregnancy. Even nearly half of those who identify as pro-choice support restrictions on late-term abortions. Indeed, fewer than 4 in 10 Democrats support abortion at any time and for any reason, which is why I'm so concerned we're considering a bill so sweeping and out of sync with the views of the majority of Americans. A bill that seeks to strip away even the most minimal protections for women and their unborn children at any stage of prenatal development. Even the original Roe versus Wade ruling never envisioned the extreme position reflected in this bill. By overturning nearly all federal and state limitations on abortion, the deceptively named Women's Health Protection Act would require the provisions of abortion on demand at any stage of pregnancy, regardless of any compelling interest in the welfare of the patient, the protection of human life, or the conscience of the health practitioner. I will oppose this bill for Oregonians like Elizabeth Gillette, who told me about her heartbreaking experience of getting an abortion in 2011. In her letter, which I would like to submit for the record, Madam Chair, Elizabeth states that, quote, on-demand abortions are not putting the safety of the woman as the highest priority. Because chemical abortion is a procedure that encompasses risk, both physical and emotional, it should not be thought of as a routine procedure. We need to protect the health of women. It's my deepest hope no woman would have to suffer as I did, close quote. And with that, I'd like to yield the remainder of my time to the gentlelady from Washington, Ms. Rogers.
Thank the ranking member and the chair for allowing me to participate today. At times like this, each one of us reflect on our own journey. As human beings, we go through so many ups and downs. I was 35 and single when I was elected to Congress. And before I met my husband, I wasn't sure about kids or if I was even a baby person. I had traveled, I had met amazing people, I'd had extraordinary opportunities that I'm grateful to God for every single day. But I can testify today that the best thing in my life has been becoming a mom. There's nothing more amazing than bringing a new life into the world. Again, there was a time when I was fearful. I was uncertain. Even when I was pregnant, it was scary. It was overwhelming. And in that moment, I could see the fear of the unknown making a person question everything. Now, I am so grateful that it happened. Today, I'm a working mom of 3. My oldest has Down syndrome, and it's one of the best things that has happened in my life. I also want to share Linda's story from Washington State. She had an abortion when she was in college, and she said, quote, "The best thing I can remember about the abortion clinic was that no one seemed to care. They didn't care that I was there to end a life. They didn't seem to care about me as a person, and they didn't follow up to make sure that I was okay. Today, Linda has 2 adult children, but she still wonders." I quote, she said, "What about the one that I aborted? What would she or he be like today?" I urge us all to remember Linda's story as some move to this extreme where nearly unlimited abortions at nearly every stage of pregnancy would be the law of the land. Our country needs hope. America needs hope and healing. Abortion doesn't bring hope or healing. There is a despair that has come over our country. You know what despair is? Despair is a complete lack of hope. It's hopelessness. I urge my colleagues to reconsider this legislation, and I yield back.
Gentleman yields back and asked for unanimous consent to have something placed in the record, so ordered. The chair now will move to our witnesses for their statements. And again, we appreciate each one of you being here. Dr. Yashika Robinson is the medical director of the Alabama Women's Center for Reproductive Alternatives. Welcome to you. Ms. Georgette Fortney, co-founder of the Silent No More Awareness Campaign. Welcome to you, and thank you. Teresa Stanton Collette is a professor of law and director of the Pro-Life Center at the University of St. Thomas School of Law in Minneapolis. Welcome to you. Nancy Northup, the president and CEO of the Center for Reproductive Rights. Thank you for being here. And Holly Alvarado, who is a retired staff sergeant of the United States Air Force. So again, thank you and welcome to each one of you. I think you are probably familiar with the lighting system. Green, obviously, is go. Yellow, you slow down. And red, you stop, okay? So Dr. Robinson, you are recognized for 5 minutes for your testimony.
Thank you, and good morning. Good morning, Chairwoman Eshoo, Ranking Member Burgess, and members of the subcommittee. My name is Dr. Yashika Robinson. I'm a board-certified obstetrician and gynecologist. I serve on the Board of Physicians for Reproductive Health, and I am the medical director of Alabama Women's Center for Reproductive Alternatives in Huntsville, Alabama. Thank you for the opportunity to speak with you in support of the Women's Health Protection Act. At my obstetrics practice, I provide prenatal care, deliver babies, and treat mothers after they give birth. I also provide abortion care because I believe that patients deserve the full spectrum of reproductive health care options. I came to this work because of my passion as a young mother. I know that I came to this work because of my passion for young people, one that is deeply connected to my personal experience. In high school, I learned that I was pregnant. As a result of fear and lack of resources, by the time I confided in my family, I had no choice. I was going to be a mother. Becoming a mother came with many harsh realities. I love my children with all my heart, but I know that everyone should be able to make the decision to parent for themselves. I am proud to provide patients with compassionate quality care when they enter our doors. and I support this bill because access to care should never depend on your zip code. In states like California or Maryland, a patient can access abortion care without the state forcing medically inaccurate information on them or making them endure a mandatory delay. This is what care should look like. Unfortunately, that is not the case for many patients in Alabama. Last year, the Alabama legislature passed a near-total ban on abortion. It would threaten doctors like myself with prison for providing ethical, medically appropriate care, for simply doing our jobs. Represented by the ACLU, I and other providers filed suit to prevent this ban from taking effect. Thankfully, it was blocked and abortion remains legal in Alabama. However, decades of medically unnecessary restrictions have taken their toll in Alabama. It is not unusual for patients to travel up to 8 hours to reach us because so many other providers have been forced to close. Then they are required to wait an additional 48 hours before I can provide the care they need. I know people who have slept in their cars overnight as a result of this state-mandated delay. The state also requires my patients to receive outdated materials as part of so-called counseling. These materials are filled with misinformation that I later have to correct. We are required to do ultrasound examinations even when they are unnecessary and provide no medical value. The effect of these needless costs and delays on my patients are so painful for me to see. Over the years, my practice has been forced to comply with onerous, medically unnecessary building requirements. For example, we were forced to install 24-hour lighting, even though we can't see patients after 5 p.m. because of a local regulation. This has nothing to do with safety at all. The local anti-abortion group even drafted legislation making it illegal to operate an abortion clinic within 2,000 feet of a school, specifically designed to shut our clinic down. A court struck that down, recognizing it as just another thinly veiled attempt to push abortion out of reach for patients. In 2018, the National Academies of Science, Engineering, and Medicine published a comprehensive study affirming that abortion is extremely safe, and the biggest threat to patient safety is the litany of medically unnecessary regulations that raise costs and delay care. They confirmed that access to safe abortion depends on where you live and how much money you have. Alabama is a state with an unconscionably high maternal and infant mortality rate. According to the Alabama Department of Public Health, nearly 2/3 of Alabama counties lack hospitals where obstetrical care is provided. In Alabama, Black women are nearly 5 times more likely to die of pregnancy-related causes than white women, and many pre-existing conditions can be made worse during pregnancy, and other serious health-related conditions can be caused by pregnancy. Without access to abortion, maternal mortality rates will rise even more. The bottom line is this: abortion is health care. The Women's Health Protection Act would bring needed federal protections for my patients and safeguard their rights. Protecting abortion will also protect access to pregnancy care because they are interconnected. Healthcare should be patient-centered, and medical decisions should remain between the patient and her physician without any political interference. Thank you.
Thank you, Dr. Robinson. Ms. Forney, you're recognized for your 5 minutes of testimony for the committee. And thank you again for being here.
Push the magic button. Do I wait till I get the green light? There we go. Thank you for inviting me to testify today. My name is Georgette Forney, and I'm here as a woman who had an abortion and has spent the last 22 years helping others who regret their abortion. Sorry, I get so emotional. As the co-founder of the Silent No More Awareness Campaign, I speak on behalf of the 19,582 people who are registered to be Silent No More. We want you to know that abortion didn't solve our problems, it just created different ones. When I was 16 and I found out I was pregnant, I was scared. The baby felt like a threat to my future. I didn't know what abortion was, but my friend told me it would fix my problem. As I drove to the clinic that day, my heart said, "This feels wrong." But the fear in me said, "It's legal, so it must be okay." For 19 years after my abortion, I pretended it was no big deal. But the reality was, I wouldn't allow myself to face the truth of what I had done. I had aborted a human being. Once I made that connection, everything changed for me. You know, as long as we stay in that place of denial, it's okay. We're okay. The problem is that sometimes something will trigger us: the birth of a child, the death of a loved one, a parent, or even a sonogram image. At the March for Life last month, 31 women shared their testimony for the first time outside of the Supreme Court. They each told why they had their abortion. They talk about what the procedure was like, what happened immediately afterwards, what were the long-term consequences, and then finally how they found help and healing. Here are some quick excerpts. Chelsea, my boyfriend, friends, and family all agreed that an abortion was the best choice for my circumstances. Lynn, I was 1 month from graduating from college and had just signed my first teaching contract. Cindy, I was told that the tugging would be like strong menstrual cramps. What I felt was intense pain, and as though not only my baby, but my soul was being suctioned out. Kelly, when I went in, I was treated with no compassion, just like a cow going off to slaughter. Laura, when I left Planned Parenthood that day, I promised myself I would never think about it or talk about this day ever again. Virginia, immediately afterwards, I forced myself to shut out the reality of what had happened. I had taken care of my problem. Cecilia, my life spiraled into a life of self-hatred, drugs, alcohol, and relationships. I ended up having 3 more abortions. Each time I felt like my life was being sucked out of me, I was dead inside, empty. Lynn, North Carolina, I became an angry, militant advocate for abortion. But over a year later, the guilt and horror of what I had done and the resulting depression, drug abuse, and self-loathing started consuming my life. The women of Silent No More speak publicly about their abortions, but many more are silent and seek help quietly. The campaign partners with more than 40 different abortion aftercare programs, helping women both nationally and internationally. One program alone, Rachel's Vineyard, has helped over 326,000 individuals. These organizations have grown as women reach out to us for help because they're dealing with nightmares, depression, suicidal feelings and attempts, eating disorders, addiction, sexual dysfunction, and most common, a low sense of self-esteem. If abortion is no big deal, why are all these people going through healing programs? Also, there is clear evidence that tighter regulations of abortion clinics are needed. Consider the filthy Gosnell Clinic in Philadelphia, where Karnamaya Monger died, or the St. Louis Planned Parenthood that failed relicensing inspection last year when the DHSS discovered 4 women had suffered from major abortion complications. Or consider preterm in Cleveland, where a hemorrhaging abortion patient had to call 911 herself after being kicked out of the clinic because they were closing. And then there are women who can't speak. Keisha Atkins died at 23 in Albuquerque during a late-term abortion. Tonya Reeves died in Chicago after bleeding for hours after 3 botched abortion attempts. She was 24 and the mother of a baby. Jennifer Merbelli was 29 when she died. Cree Irwin was 24 when she died of an incomplete abortion in Michigan. Tell the families of these women that abortion must be protected. You say that abortion restrictions impact women of color, but the inconvenient truth is that women of color are being killed in the recent years more than the white women, like Cree, Tonya, and Keisha. Or how about Lakeisha Wilson, Jamie Lee Morales, or Maria Santiago? Do their Black lives and Hispanic lives matter? We need legislation that requires every state to report every abortion, every incident of physical harm by abortion, and every woman that dies by legal abortion is acknowledged. Let's get the facts. Trust women
Ms.
with
Forney,
the facts,
you're-
not rhetoric. Thank you.
Almost a minute over time. Thank you for your testimony. I now would like to recognize Ms. Stanton Collette for your 5 minutes for testimony.
Thank you, Madam Chair.
Turn your microphone on.
Thank you, Madam Chair.
Great, that's good.
Ranking Member Burgess, members of the subcommittee. My name is Teresa Collette. I'm a law professor in Minneapolis, as the chairwoman mentioned. I also, however, have a fairly robust litigation practice.
Madam Chair, she may need to pull her mic a little bit closer to her.
Thank you. I also have a fairly robust litigation practice and have represented numerous public officials in amicus briefs before the U.S. Supreme Court, federal courts of appeals, and state Supreme Courts. I've also had the privilege of serving as Special Attorney General or Special Counsel to the states of Oklahoma, New Hampshire, and also in Kansas. That is the basis of my testimony today, which represents my personal views, not the views of my employer, the University of St. Thomas. It is important to note what is absent from this bill at the outset. Number one, while the bill recognizes that abortion is constitutionally protected, it fails to recognize the unique nature of abortion. Abortion, unlike the other procedures that are listed as comparable procedures in the legislation, in the words of the Eighth Circuit, ends the separate, unique human life. There is no other medical procedure that is undertaken in this country where that is permitted. It is also important to note that many of the premises of this bill are simply false. The first congressional finding in the bill suggests that abortion access is a necessary precondition to women's full participation in the economic and social life of this country. To that extent, it is a version of what the Supreme Court plurality said in Planned Parenthood versus Casey. But when that case was decided, abortion rates were already beginning their steep decline. The simple fact is that from 1991 to 2016, the last year in which we have statistics from the CDC regarding the rate of abortion, abortions have declined more than 50%, going from an annual rate of 24 per thousand women to 11.6. During that time period, women's participation in the workforce has remained largely steady, including participation by women who have children under the age of 18. During that time also, women's educational achievement has skyrocketed. According to the Bureau of Labor Statistics, women's college degrees have quadrupled from 1970 to 2018. In addition to that, women-owned businesses have increased 42%, according to the American Express study in 2019 of women's businesses. They contribute $1.9 trillion to the national economy. The simple fact is there is no correlation between access to abortion and women's participation in the economic and social life of this country. To the extent that there is a correlation, it appears to be a negative correlation. But I won't insult the members of this committee by suggesting that's a truth. We all know that correlation and causation are very different things. But women are succeeding in this society while abortion rates are falling rapidly. There is no correlation. My second point is that the restructuring of the abortion market is in response to that steep decline. While it is said many times already today that abortion access is a necessary component of health care, the committee ignores in this legislation the fact that 54% of all counties in this country have no hospitals providing obstetric services. Dr. Robinson testified to that fact today and said in Alabama it's an even greater number of hospitals that provide no obstetric services. That is an outrage. If you were really concerned about women's health, that would be your primary concern. In addition to that, we also see that there is a restructuring by the major market force in that industry. The industry, of course, is led by Planned Parenthood, who has adopted as a strategy the building of mega clinics. When markets are declining, you need economies of scale. That makes sense to me. In the state of Texas, they have built a mega clinic that in 2014 expanded their ability to serve women by 1,000. But when Walmart comes to town, you expect smaller businesses to close. The fact that these clinics are closing that compete with Planned Parenthood is much more a product of market forces than it is by any regulation. And in fact, researchers at Guttmacher have said that they cannot explain with certainty what's causing the decline or what the impact of these regulations are on that decline. It's also important, finally, to note that this legislation is based on studies that are predominantly done by the abortion industry itself. It would be comparable to trying to pass tobacco regulation based on the Tobacco Research Institute, an institute that was funded by the industry and that suppressed studies that were contrary to its economic interests and its economic desires. That is true in this area as well. Again, if this committee were interested in women's health truly, they would be passing legislation that would require all states to report to the CDC the rate of abortions, the injuries from abortions, the age and gestational age of the child. They would also require and fund studies done by independent researchers. Thank you, Madam Chair.
Thank you. I now would like to recognize Ms. Northup for your 5 minutes of testimony, and welcome and thank you again.
Thank you, Chairwoman Eshoo.
You want to put on your microphone, please?
Thank you, Chairwoman Eshoo, Ranking Member Burgess, and members of the subcommittee for inviting me to speak at this important hearing this morning. Right now, one of the most basic protections of our Constitution, the right to make for ourselves the important decisions of our lives, is under attack. As you have heard this morning, since 2011, states have enacted over 450 laws as part of a coordinated nationwide strategy to make it harder and sometimes impossible for women to access abortion care. Last year, in 2019, we saw extreme abortion bans enacted in state after state. These attacks come against the backdrop of the president's vow to appoint justices to the Supreme Court who will overturn Roe v. Wade. And judges hostile to reproductive rights are being confirmed on our federal trial and appellate courts. Recently, people across the nation have been calling on Congress to stand up for women and codify Roe. The Women's Health Protection Act is the answer to that call. The moment is now to draw the line on the decades of assaults on women's rights. My name is Nancy Northup, and I'm president and CEO of the Center for Reproductive Rights. We're a nonpartisan, nonprofit, legal organization working to ensure that reproductive rights are protected as fundamental human rights around the world. Since our founding in 1992, we have litigated hundreds of cases in state and federal courts, including in the Supreme Court, where we will be back in 3 weeks. I have led the Center for 17 years, and I have been an abortion rights advocate for far longer than that. Never have I been as concerned as I am today about the promise of Roe being hollowed out for too many women in this country. 47 years ago, the Supreme Court recognized in Roe that the right of personal liberty guaranteed in the 14th Amendment includes the decision by a woman to end her pregnancy. As the court would later explain, it is the promise of the Constitution that there is a realm of personal liberty that the government may not enter. This protective realm is the hallmark of a free society. It is for each one of us, and not the government, to decide for ourselves the intimate and profound choices of our lives that we're hearing about this morning. These choices include whether and who we choose to marry, whether and when to have children, and how we raise our children with our values and our beliefs. The commitment of Roe to women is that we, too, are guaranteed the dignity and respect to make the critical decisions about our bodies, our health, and our lives. That guarantee is being obliterated by the avalanche of restrictions that have been designed to make the right to abortion unavailable in fact. Where not blocked by court orders, this new wave of restrictions are closing clinics, exacerbating inequalities, and harming women and their families. The 2019 state legislative session marked a new level of extremism. including 9 blatantly unconstitutional bans, such as the blanket Alabama ban. New restrictions are still moving through the legislatures as we sit here today. 90% of American counties have no abortion providers, and 6 states have but 1 clinic. The impact of these restricted laws are deeply unequal, falling most heavily on people who already experience significant systemic barriers to quality health care, including those who are women of color, low income, rural, immigrants, LGBTQ, young, and living with disabilities. That is why Congress needs to pass the Women's Health Protection Act. The bill creates a statutory right for health care providers to provide care and a corresponding right for their patients to receive care free of medically unnecessary limitations and bans that single out abortion and impede access to services. It is a meaningful, concrete step to ensuring that Roe is real for all women. The Women's Health Protection Act is targeted at a specific problem on medically unjustified laws and bans. Access is also denied to women in this country for other reasons, including discriminatory restrictions on insurance coverage like the Hyde Amendment. Other important abortion access bills, most notably the Each Woman Act, are needed to address this inequality. After so many years of chipping away at Roe, multiple efforts are needed to restore access to abortion care. 1 in 4 women in the United States will make the decision at some point in her life that ending a pregnancy is the right decision for her. These are women from all walks of life. They live in every state. They live in every one of your congressional districts. They are our loved ones, our neighbors, and our colleagues. A woman's decision is based on her individual circumstances, her health, and her life.
Ms. Norton, your time has expired. One more sentence to wind up.
It is time for Congress to act. I urge this members to send the act to the floor.
Thank you very much. It's a pleasure to recognize Ms. Alvarado. You have 5 minutes for your testimony, and thank you again for being with us.
Thank you, Chairwoman Eshoo and Ranking Member Burgess and members of the subcommittee for inviting me to testify today. My name is Holly Alvarado, and I'm here to share my story. In 2009, I faced multiple barriers in accessing abortion care due to burdensome and medically unnecessary state abortion restrictions. I'm here today to show you how important it is that you pass the Women's Health Protection Act. I served in the United States Air Force from 2006 to 2011 as a law enforcement officer. I was motivated to serve my country as the granddaughter of Mexican immigrants. I had seen my family build their American dream and felt grateful to this nation. I served honorably, earned the rank of staff sergeant, and became an instructor. I am proud of my service to this country. In 2009, I was given orders for deployment. While preparing for deployment in the middle of a Walmart shopping for supplies, vomiting in the middle of an aisle, I realized I could be pregnant. It felt like I was a fast car going 100 miles per hour, and then someone hit the brakes. I took the time to think about how I was not financially or emotionally in a stage of my life where I was ready to continue a pregnancy and raise a child. To end my pregnancy, I would need to immediately coordinate an appointment, an abortion, approval to take leave from work, and find time between all of these things to still continue preparing for deployment in 2 weeks. I called Planned Parenthood of North Dakota and learned that the closest facility that could perform abortions was in Fargo, North Dakota, 2 hours from me. North Dakota only has 1 abortion clinic, which means longer wait times for an appointment. They did not have any appointments in the next 2 weeks before deployment and was unable to help me. I was encouraged to call St. Paul, Minnesota, 4 hours away. I called and scheduled my first and second appointment. My first appointment was needed to verify my pregnancy with an ultrasound and urinalysis. They gave me information and an ultrasound picture. I needed to book a second appointment for the procedure itself. This was not due to any medical reason, and it was certainly not my preference. Minnesota state laws mandate a 24-hour waiting period between the first appointment and the day of the procedure. And because of the wait times for an appointment, at the clinic, I would have to wait 3 days between the appointments. I would spend a total of 4 days in Minnesota without resources. Due to Minnesota state law, I would also be required to endure scripted counseling, including information that portrayed abortion as unsafe and a threat to my future fertility. Only after this could I confirm my appointment for the next day. I ended the phone call secure in my decision to not continue the pregnancy. I did not need or benefit from the mandated waiting period, the resulting 600-mile round trip, the biased counseling, or the protesters in front of the Planned Parenthood. It was not a cold or bleak decision on my behalf, rather a compassionate one for myself and the life and potential I wanted in my own future. On top of all of this, I also faced an enormous financial burden. Because of the federal ban on abortion coverage, I was unable to use TRICARE as my healthcare insurance. The procedure for an abortion is approximately $500. In addition to purchasing gear for deployment, needs for gas and food for the 4-hour, 600-mile round trip, I had $16 to my name the day I drove back to North Dakota. A week and a half later, I would fly to Afghanistan with almost no money to my name. The environment in Planned Parenthood of Minnesota was compassionate. The clinic provided an escort to walk me through a line of shouting protesters trying to redirect me to a fake clinic nearby. When I finally made it to the exam table, my doctor asked me, "Is this what you want?" We took a pause together. I shared that I never wanted to be pregnant. I never wanted to travel to Minnesota. I never wanted to jump through all of these hoops to obtain an abortion. But I knew that this was a pregnancy I did not want to continue, and ultimately knew this was the right decision for my life. When the procedure was complete, I felt relief. I was 22 and knew what now 33-year-old me wanted out of life and her future. I was confident that the trajectory of my life was changed for the better because I was able to make the best decision for myself and my life. I was a trusted law enforcement officer charged with defending my team and resources, taught federal use of force and lethal force. I am a decorated campaign veteran who was taught Geneva Conventions, NATO rules of engagement, and trusted to be competent in my abilities enough to teach them to future airmen. Yet when making a decision over my own life, I was not trusted to know what was best for myself. Several state laws made that very clear to me. The decision to continue or end a pregnancy is a healthcare decision that cannot be made by one individual for another individual. I cannot reconcile that our government trusted me to hold weapons of protection for our country and serve as a respected member of our armed services, but could not trust me to make the right decision over my own body. I have no regrets about my decision to end my pregnancy. I was honorably discharged from the military and decorated after my tour in Afghanistan. I received my education in public health, traveled the world, met my partner, and now professionally support families making healthcare decisions. I am proud of the life I now live.
Ms. Alvarado, your time has expired.
Thank you, ma'am.
Just, finish with a sentence to wrap up.
I urge you to pass the Women's Health Protection Act so that no one else has to face the barriers that I did. Thank you.
Thank you very much. Concluded the statements of all of our witnesses. We thank you again. We're now going to move to member questions, and I recognize myself for 5 minutes of questions. But I first want to start out with a couple of comments to some of the comments that have been made by my colleagues. That there are no safety codifications in this legislation. That simply is not so. As long as the state has evidence to show that the restrictions increase women's safety, then the regulations would stand. So there's a direct correlation between the safety of the patient and regulations, and that's very important for each one of us. We all expect those standards to apply to us when we're, especially in a medical setting. In terms of viability, the bill acknowledges that viability varies on a case-by-case basis, and that the judgment of a viability should be made by a physician, not a politician. And I just can't emphasize that enough. And it upholds the Roe standard of viability. I also think it's very important to highlight, to underscore the following. Very little is being said about contraception. I don't know anyone on this panel, and I'm not going to ask, but there are very few here that have 11, 12, and 15 children. So something is working somewhere, and it is. And the The Guttmacher Institute found that, quote, "The evidence clearly indicates that the more and better contraceptive use has been the main factor driving the long-term decline in teen pregnancy." There is a correlation there between the historic low that has been reached after the passage of the Affordable Care Act, because, of course, there is coverage for contraception. So now let me get to my questions with the 3 minutes and 30 seconds that I have. I want to go to Nancy Northrup. Thank you for your work over so many years. Roe v. Wade established the right to an abortion nearly 50 years ago, as you testified. That's almost a half a century ago. Imagine that, a half a century ago. But can you speak to the disparities given what the 450 laws that have been passed between a woman living in, say, Fort Worth or Fort Wayne, Indiana, what they get to exercise in terms of a right, and a woman living in my community in Palo Alto, California? Because I think that these disparities are deep and they're wide and they need to be emphasized. So can you comment on that first, please? Your microphone.
So the constitutional standard is strong, and as you say, almost 50 years, that each of us has the constitutional right to make this decision pre-viability. But the reality is, because of restrictions, that there are vast differences. And those differences include the ones that Ms. Alvarado testified to about having to make multiple trips, having to have scripted, unmedically based information that the doctor must give to the patient, the depriving of health insurance coverage, which Ms. Alvarado also talked about. And so we have a situation in the United States today where, in a place like California, where there is access to services in people's own communities, and other states, the state of Louisiana, which is going to be before the Supreme Court in 3 weeks, and we're representing the clinic in Shreveport there, there's only 3 clinics left in the state of Louisiana, one in New Orleans, one in Baton Rouge, and one in Shreveport. And if the law were to go into effect, if we are not able to win this case in the Supreme Court, Louisiana will be down to 1 clinic, 1 doctor for the entire state, for 1 million women.
I mean, the record is really very full relative to these deep and wide discrepancies. So it's based on zip code. It defies what the Supreme Court decided. And if you live in any of these states and you're a woman, politicians are going to make the decision. You have nothing to do with your future. I recognize fully that there are those that would and that have the right to in our country to choose not to undergo an abortion. That's what the word choice means. But this is forcing people to do one thing. So it wipes out choice. Dr. Robinson, can you describe for us, of course, abortion care in Alabama is legal. Walk me through, or walk us through, exactly what happens. To say that it's legal, however. What comes after that comma of however?
Sorry. Despite the fact that abortion care is legal in Alabama, we only have 3 clinics to service the whole state. And with that being said, our facility actually services patients from 5 states because of restrictions that have closed clinics in the other areas or restricted the gestational age. So even though there are other areas that have clinics, we have patients that have to travel very far to get to us. What that means is that women, especially those that come from a low-income family who are already struggling to make ends meet, it may be difficult for them to access care despite the fact that there's a facility there in Alabama.
Was the penalty of 99 years for doctors passed in Alabama and then struck down by lower court?
That's correct.
99 years for a doctor. I mean, that is enough to take anyone's breath away. I'm out of time, and I now would like to recognize Dr. Burgess, the ranking member of the subcommittee.
And again, I thank the chair. Just before I started my questions, I do feel obligated to point out that there is a serious illness going on half a world away, and I do hope this subcommittee, which has the primary jurisdiction over health, will take that up seriously some point in the near future. We've waited some time for that, with a formal hearing, not just a briefing. Now, I do want to thank our witnesses for being here today.
If I could just say something, Mr. Burgess, the subcommittee is certainly not ignoring the coronavirus. We have had classified briefings that have been very important. We have had open briefings where we have all participated. And I feel as up to date on the information as is possible. And we will have a hearing with other stakeholders from outside of the administration to advise us. But in no way, Dr. Burgess, and I think that you know this, are we ignoring this. We have scheduled the end of this month the hearing with the Secretary of HHS. He was the one that wanted to come in and do the briefing. He said, I'm the one that should be doing it and not anyone else. He gave us the date. I said, terrific. I will welcome you. We will all welcome you. So to suggest that we're ignoring the coronavirus is simply not so.
But as you know, a hearing is different from a briefing, and there's no transcript from a briefing.
We had a hearing with the Secretary. I just explained to you. He wanted to come. He
Yeah.
said, I'm the top person. I'm the one that wants to do it.
I don't want to spend
So
any
I said,
more-
yes.
I don't want to spend any more
Well, I
time
want to
with this
respond because
debate.
you're suggesting that we're ignoring
I'm
it. We're
simply
not.
suggesting it is an important issue that we need to take up. I do want to thank our witnesses for being here today. Ms. Alvarado, thank you for your service to the country. I know it's a difficult subject, and I guess Ms. Forney and Ms. Collette, I would like to ask you, both of you referenced data collection and data reporting. How do each of you think that that would make a difference if we were to engage in that aggressive data collection, data reporting that you've both described? Where would that go?
I would say that the key to this is that we would have real information, facts, as opposed to estimations. The fact that there are certain states that don't even submit their data for the CDC makes it impossible for us to really follow the numbers and track injuries and deaths. Whenever a woman dies by abortion, the underlying cause is featured instead of the abortion on the death certificate. These things are creating data confusion, if you will. So I believe that if we're really interested in caring about women, we start with getting good information so we're not using data from organizations that have predetermined agendas.
Congressman Burgess, the fact is that to the extent there is good data, it's largely from European countries where they have universal health care, and that creates a database for the investigators that want to look at the psychological harms that can arise from abortion, whether they were based on a pre-existing psychological weakness. They also have better data on the correlation between suicide and post-abortion experience. So we don't have a comprehensive healthcare system, and I am glad we don't, frankly, but we could have comprehensive reporting, which we simply do not have in this country. Even Stanley Henshaw, the former demographer for Planned Parenthood and who worked at Guttmacher, has complained that the data that they have is incomplete. 80% of the abortions in this country are reported to the CDC, but that leaves 20% with no reports on them, including the state of California.
Well, it's just interesting. Yesterday in a different subcommittee, we had a hearing on self-driving cars. I realize that sounds unrelated, but the almost universal and all of the witnesses that were there was the acknowledgement that we needed good data on safety and accidents, and to be able to legislate around that space was virtually required to have the information. That's why when both of you brought that up this morning, it struck me that that is something that where I think we would all benefit. Ms. Collette, let me just ask you, because so much is made on the statement of no restriction prior to viability and the age at viability, is that something that was set in court decree, or has that ever been set in statute, the determination of viability?
In fact, the U.S. Supreme Court has addressed statutes that attempted to statutorily define the stage of viability. And as Dr. Robinson and Ms. Northrup testified, the court has held that it is an individual physician's decision, which, based on, you as a doctor know that there are certain conditions, prenatal conditions, that would affect the viability of the pregnancy in general. So that statement regarding the standard is correct. But the Supreme Court has always upheld the right of states to regulate. Early on, it was the second trimester for women's health, and then in the last trimester, of course, to protect the unborn life. And now under Casey, that's not even the standard. The standard is, does the law create a substantial obstacle to a woman's access to abortion?
But it strikes me during the continuum of my professional career, that level of viability has Parkland Hospital, we were told we had to get a gestation of 33 weeks if there's going to be any hope. 23 weeks was my individual level, and then we saw at the State of the Union 21 weeks. So it does seem to be changing. Are we technically capable of keeping up with the fact that the actual length of gestation is changing for viability?
We are seeing many legislatures examine that very question, and sometimes it's not simply the duration of viability, but as well as the weight, the estimate of weight, which is why ultrasound is so important.
Great. Thank you. I yield back.
The gentleman yields back. Pleasure to recognize the chairman of the full committee, Mr. Pallone, for his 5 minutes of questions.
Thank you, Madam Chair, and I want to thank the witnesses for being here, because this hearing is an important step towards, or forward, I should say, in protecting access to abortion and stopping unnecessary state laws that intrude on a woman's ability to exercise her constitutionally protected right to abortion. But I wanted to focus on the actual bill today and what that means for abortion access. So let me start with Ms. Northrup. Will you discuss why you believe the Women's Health Protection Act is necessary and what effect the bill would have if it became law? Briefly.
So yes, necessary. Yes, necessary, as we've been talking about this morning, the avalanche of laws. And what the Women's Health Protection Act does is make sure that doctors have a right to provide services free from unnecessary regulations and unscientific regulations, and women have a right to get that care. And what it does is both specify the type of medically unnecessary laws that are burdensome, so admitting privileges, like we're twice up in the Supreme Court fighting about that, even though the Supreme Court has decided, waiting periods that aren't medically necessary, the kind of hallmark or hallway restrictions and so forth that aren't necessary, and that it also provides a broader test for new kinds of things that will come up to make sure that they are medically based. And the reason why it's necessary, even though we win hundreds of cases, including the last one in the Supreme Court, even after we won that Supreme Court case, over 100 new restrictions were passed in the state, disregarding the Supreme Court's clear guidance that you have to actually advance women's health. The Supreme Court found that Texas's admitting privileges did not advance women's health, but the laws keep coming. We need a statute that makes it clear that we're going to have fact-based, medically based, scientifically based regulations, not these underhanded tactics to shut clinics and block women from care.
Well, thank you. Dr. Robinson, how would the bill change your practice if healthcare providers had a statutory right to provide abortion services and that your patients would also have a right to receive such services? Briefly.
Well, we know that abortion care needs to be safe and it needs to be readily accessible for all patients. And these restrictions are making it where it places barriers that makes it more difficult for these patients to access the care that they need. So the Women's Health Protection Act will ensure that patients can receive the care they need without constant regulations coming down that are constantly chipping away at that care.
All right, thank you. Now back to Ms. Northrup, and maybe just yes or no. Would the bill in any way require or mandate that providers provide abortion if they did not want to? And can you describe how the bill would impact the limitations and restrictions that have been placed on abortion care at the state level? For example, would the requirement that a provider offer medically inaccurate information in advance of an abortion be allowed to stand? Why don't you just address that since you kind of addressed the others before?
No, you can't. No, you cannot. The Women's Health Protection Act would stop these laws that require doctors to provide medically inaccurate information to women. So, for example, right now there are many state laws that are requiring doctors to tell women that medication abortion is reversible. I mean, that is scientifically untrue. The American Medical Association is suing the state of North Dakota on behalf of the doctors in that state to say you cannot force doctors to tell patients things that aren't true.
All right. Now, it's my understanding that the bill specifically ensures that state laws can be maintained if they demonstrate that the requirement significantly advances the safety of abortion services or the health of patients. Is that correct?
Absolutely.
Well, given this, is there anything in the bill that would make the provision of abortion care less safe? Because I know we've heard that from some of the...
Absolutely not, and has been clear by the American Medical Association, including in their brief they just filed in the Supreme Court, abortion is a safe procedure.
Okay. I just want to thank you. The bill, in my opinion, is critical to ensuring that healthcare providers can provide the care they're trained to provide, free of unnecessary restrictions. I always worry about, efforts on the federal level, let alone the state level, where we try to tell doctors what they should do or not do, even though they're the experts. And, so I think it's important that patients get the care they need and that they're constitutionally entitled to. And I'm proud to support the bill, and I believe it's an important legislative solution to protect access to abortion, which increasingly is not available. And as Dr. Robinson pointed out, it can't be that in New Jersey you can get an abortion, but in Alabama it's almost impossible. So I appreciate all of your statements. Thank you. Thank you, Madam Chair.
The gentleman yields, and it's a pleasure to recognize the gentleman from Illinois, Mr. Shimkus, for his 5 minutes of questioning.
Thank you, Madam Chairman. Before I start, I just want to congratulate you and my colleagues. This is such a tough issue, and if we continue to deal with this with dignity and respect, I think it'll bring some luster back onto the legislative branch that we can have this tough discussion. We got a lot of diversity in this hearing room. Why are we, as individual humans, diverse? What is it that makes us different? Anyone know on the panel? Anyone? Okay, we all have separate DNA. It's our DNA strand that defines who we are and all our differences, red hair, blonde, black hair. And when is a separate DNA formed, Dr. Robinson, of an individual? I mean, you're a doctor, so you should know this. When is a separate, distinct DNA of an individual formed?
I don't know that question has ever been posed to me or that I've thought about it. So
Okay, well,
I'm not
let me
really
just
sure.
say, anyone want to answer that question? Ms. Collette?
Congressman, Dr. Jerome Lejeune provided comprehensive testimony on this point at a trial court level in Tennessee. That testimony is available, and I'd be happy to forward it to your office.
But
It's at the moment that the sperm and the egg unite.
it's at the moment of conception. Half the DNA.
Conception in the medical literature has changed, so it's at the moment of fertilization. Some medical journals use conception to mean implantation.
Okay, well, thank you for that. The point being is that half of the DNA comes from the woman, half from the male, and that makes you distinct, separate entity. And I think that's important. When does a child's heart begin to beat on its own inside the womb? Anyone know? Ms. Forney?
I believe it's 28 days.
6 to 7 weeks is what most.
No, I mean, I think it's 28 days, which would be more like 4 weeks. 5
Dr.
weeks.
Robinson?
I don't know the exact answer to that, but I know
Can you
that
give me a
based off
ballpark?
of,
Can you give me a ballpark?
well, I can tell you what I
Is
see in my
6 to
practice.
No,
Usually
it's
around
6
6 weeks,
all right,
I can see cardiac
reclaiming
activity
my
on
time.
ultrasound.
Reclaiming my time. When does the brain activity of an unborn child start occurring? Anyone want to? I think the scientific literature says 6 to 7 weeks, maybe even before that. Then the age of viability, 23 states identify either between 20 weeks to 24 weeks as the age of viability, from Mississippi to Pennsylvania. The president did have, as was mentioned, a child in the gallery who was 21 weeks and 6 days old, who is now a healthy 2-year-old child. Under this bill, would it be legal to abort an unborn baby at 21 weeks? Ms. Forney? Just answer it.
I believe it is, because
Okay.
the whole idea is to remove all restrictions.
Okay,
I have not read
let me
the
go to
bill,
Ms.
so-
Collette.
Congressman, the bill allows post-viability and pre-viability post-viability based on health. Pre-viability must be unrestricted, and so yes.
Okay, so here's the other concerns and troubles I have with, we had a debate on a chemical substance, per and polyfluorinated compounds. We tried to address the issue of vulnerable populations, and we tried to make sure that it comported with federal law, which was the Unborn Victims of Violence Act. We know that it is against the law, and you are considered a capital criminal crime if you attack a pregnant woman and that unborn baby dies. Is that correct?
Congressman, in fact, New York revised its laws, so it is no longer an independent crime. It is simply a consideration.
But public law, which we passed here, 108-212, the Unborn Victims of Violence Act, identifies the unborn child in any part of pregnancy, even prior to the age that they could live, in essence, outside the womb. Is that correct?
That is correct.
Madam Chairman, thank you. My time's expired.
The gentleman yields back. It's a pleasure to recognize the gentleman from New York, Mr. Engel, for his 5 minutes of questions.
Thank you, Madam Chair, and thank you to all the witnesses. Let me start with Ms. Alvarado. I want to thank you for your service, first of all, and I was very moved by the fact that we rely on you to keep us safe, but we, in some instances, don't want to give you the opportunity to do what you feel is right with your own body, and I thought that your testimony was very, very heartfelt.
Thank you.
The abortion issue has always been an issue that both sides take stands and kind of butt heads with each other. My third child was born when I was 46 years old, and my wife was 40. We didn't expect it. And we made a choice to have the child, but that was our choice. I do think that people have the right to make that choice for themselves, and people who feel that abortion is not something they'd consider for moral reasons or anything else, then I believe that they need to do whatever they feel in their heart. But I don't believe that they ought to be restricting other people who may feel differently, and that to me is very, very important. Now, since 2011, we've seen a tide of Republican-controlled states pass about 450 medically unnecessary restrictions that limit access to abortion care and make it harder for women to get comprehensive health care services. Ms. Northup, can you describe how these state laws and restrictions limit access to abortion care, and what the outcomes have been in states that have enacted them?
Yes, the outcome of these state restrictions, many which are designed to make it very hard to provide abortion services, is that clinics do in fact close. And when clinics close, women have to travel farther. They need to take time off. They need to sometimes make multiple trips and drive hundreds of thousands of miles. And an example of this is the state of Texas, which is the case we took to the Supreme Court in Whole Women's Health versus Hellerstedt. Texas passed an admitting privileges law, which is not medically justified, which the Supreme Court found did not advance women's health at all, because hospitals within 30 miles of an abortion provider can turn down admitting privileges for every reason that they want. Economic basis of the hospital, or that they don't like the provision of abortion services, and they're not going to give providers privileges. And half the clinics in the state of Texas closed. And that was the case until we won the Supreme Court case, and they could never reopen because it had been years of litigation. So it's an example of the devastation, and when those clinics close, it's not just abortion services that lost, but can be family planning services, STI services, and other important parts of women's health care.
Well, how do states justify these laws when they know that so many of these restrictions are designed to limit access to what's really a constitutionally protected right?
Well, I think it shows the fact that they are pretextual laws. They purport that they're about health care, but it's proved in court case after court case that they're not. And again, it's why the American Medical Association and 14 medical groups have filed a brief in the Supreme Court, in the case to be argued in 3 weeks, to say that abortion is a safe procedure, and the admitting privilege law in Louisiana, just like Texas, doesn't advance women's health.
Well, a number of the state laws and regulations you've described have been struck down by the courts, and most notably in 2016, as you just mentioned, the Supreme Court struck down 2 Texas state laws that required abortion providers to have hospital admitting privileges and retrofit their clinics as ambulatory surgical centers. So could you again tell us why it's critical that we have a legislative solution to address state abortion restrictions instead of just relying on the courts to ensure that the constitutional right to abortion is maintained?
Absolutely. So for those of us who litigate in the courts, it's like playing whack-a-mole. We win a case, and the next thing comes up again. After Whole Women's Health, more than 100 restrictions have been passed. The Women's Health Protection Act would provide statutory guidelines that are very clear about what is not permitted, and also a statutory test that would make sure that courts had to follow it. Right now, unfortunately, some courts are not following the Supreme Court's jurisprudence, and that's the case in Louisiana with the U.S. Court of Appeals for the Fifth Circuit, which is why we're back in the Supreme Court again on the same issue we already won. And also, we don't want to necessarily rely only on the courts. Congress has the authority to protect our constitutional rights as well.
Thank you. I know my time is up. Thank you, Madam Chair.
The gentleman yields back. The pleasure to recognize the gentleman from Kentucky, Mr. Guthrie, for his 5 minutes of questions.
Thank you very much. When we were having our first child, she's 26 now, almost 27 years ago, we went to, we thought we were going to have twins, or we thought there could be twins, so back then they did the ultrasound, and at 10 weeks old, she was the size of a Teddy Graham, and if you're not as old as I am, I guess about the size of a gummy bear. She was sucking her thumb and had her own little personality and her own, so, I mean, no matter where you are on this issue, you can't deny these are human beings. I mean, and where you feel they have the right to life or not, that's a different question, I guess, for some people, but they are human beings. Well, now my 26-year-old is going to have our first grandbaby. When she was 13 or 14 weeks along, we went to see the ultrasound, and our little granddaughter, to be, and hopefully May 19th, was sucking her thumb just like her mother. And it was just amazing. That was almost looking at the same picture, other than it's clearer. And so these are distinct and individuals and with their own personalities, and they require their mothers to come into this world and to be and get into life. And so as we were looking at some of the questions just my colleague just asked, I was going to ask about, so H.R. 2975 states that women's health access to health care is reduced because of anti-abortion laws. And Ms. Collette, I mean, if you just kind of answer, maybe rebut some of the stuff that we just heard. My understanding is they have federal qualified health centers are available. Just because a place providing abortion services isn't available everywhere doesn't mean women aren't getting access to good health care. Could you comment on what was just said?
Certainly. Ms. Northrup, I believe, mischaracterized the Hellerstedt case. The Texas evidentiary record in that case was that there were some difficulties in obtaining admitting privileges, but they did not have the legislative record, nor did they have the disciplinary record of physicians and clinics that exists in Louisiana. In my written testimony, which I would ask to have submitted as part of the record, I actually quote the Fifth Circuit's.
All written testimonies are part of the record.
Thank you, Madam Chair. I quote Judge Elrod of the Fifth Circuit, where she notes that there was even a challenge on the part of the abortion clinics as to whether the Supreme Court could see the evidentiary record because of the overbroad protective order that was given at the trial court level. Nonetheless, the Louisiana Department of Health has multiple findings that clinics had unsanitary conditions, that physicians were that were hired were unqualified in the area. In one case, they hired an ophthalmologist to perform abortions. And so the record in the Louisiana case is very, very different than the record that was in Hellerstedt. I'm very optimistic, in fact, that the state of Louisiana will prevail in that case. But that's the distinction. As far as access, even the Guttmacher Institute has published multiple papers showing that regulation is not the primary cause for the decline in access. They have, as late as 2018, said that there are other reasons for the decline of the abortion rates, that while it is a factor, things like the fact that abortion rates have declined by 50%, women are making different choices. And when you lose 50% of your market for services, you are going to have clinics close. It's very simple. And as I testified earlier, Planned Parenthood has this strategy of mega clinics now. One exists in St. Paul, near my home. Another exists in Houston. The newspapers report that they expect to increase their patient rate to 1,000 more people. That's going to affect the smaller clinics. And as Dr. Robinson herself testified, there are times when clinics are located nearby, but that patients choose to go to other clinics for various reasons. Part of it might be the reputation of the clinic in part. So the simple fact is that as far as STI treatment, as far as prenatal care, that is available from other facilities. And if you really are worried about women's health, let's deal with the fact that over 50% of the counties in this country do not provide obstetrical care in their hospitals.
Well, thanks. I also have a question. So the bill before us, H.R. 2975, forces states to allow abortion regardless of a patient's reasons for seeking abortion. Does that mean that you can have an abortion for any reason, along with this bill, Ms. Collette?
Congressman, that is the state of the law currently pre-viability, and even in many states post-viability. For example, in my home state of Minnesota.
So I only have 15. So sex selection would be a
sex selection would be
reason?
permitted, yes, as would for racial reasons or for the disabilities of the child.
Okay, thank you. I only have 5 seconds. So that's another question, so I'll yield back. Thank you for your answer.
The gentleman yields back. It's a pleasure to recognize the gentleman from North Carolina, Mr. Butterfield, for his 5 minutes of questions.
Thank you very much, Madam Chair, for yielding time, and let me thank the 5 witnesses for their testimony today. I know this is an important topic that we all must continue to have a conversation about. I spent 30 years in a courtroom, 15 years as a lawyer, 15 years as a judge, and I know that people feel very strongly about this subject. Years ago, I was very conflicted on the whole subject of abortion and where I should come down as an American citizen, as a human being. But Roe versus Wade seems to be the guiding star. That is the law of the land, and that's what's guiding me in my thinking. And so I want to first begin by saying that I'm struck that the Supreme Court has chosen to consider a case that will reevaluate settled law and once again throw into question nearly 50 years of precedent. And so that's where I want to go this morning. Ms. Northrup, before I go to Ms. Northrup, let me just ask Ms. Collette, we keep straying away from the whole conversation about contraception. Where are you on contraception? Do you support contraception as a means of birth control?
Congressman, that question was answered by the Supreme Court in the Eisenstadt case as well as...
I'm talking about Ms. Collette. Where are you on contraception?
I am postmenopausal, Congressman, so it's really not a relevant question to me.
Well, I determine what's relevant, and I would hope that you would answer the question. But let me continue. Time is precious. Ms. Northrup, can you tell us a little bit about this case the Center for Reproductive Rights is currently litigating, and what the outcome means for abortion jurisprudence in this country?
Yes, so as I've testified before, the Center for Reproductive Rights won the case of Whole Women's Health versus Hellerstedt against Texas, both striking down its admitting privileges law and its requirement that every abortion clinic in Texas be an ambulatory surgical center. The state of Louisiana, despite that ruling, has persisted in insisting that it can have an admitting privileges law, and that admitting privileges law will have just as devastating effects in Louisiana. It would close all but one clinic and leave 1 million women in the state of Louisiana to have access to just one abortion provider. And so the district court agreed that it was unconstitutional. It found that it had no medical basis, as in the Texas case in the Supreme Court, and that it would harm women. The U.S. Court of the Fifth Circuit, as we were arguing in the Supreme Court, disregarded both the fact findings of the trial court and disregarded the Supreme Court's standard. So we are back in the Supreme Court to make sure this law doesn't go into
You're a
effect.
501c3, is that right? Or
Yes,
C4?
we are.
C3.
Yes, we are
All
a
right,
nonprofit.
okay.
That is correct.
All right.
I would also like to just straighten out what was said by Ms. Collette about the Louisiana case. Louisiana indeed tried to muddy up the record and put allegations that she went through into the record. The Supreme Court denied their attempt to do that.
Is it fair to say that the major difference between the June medical case and the 2016 Whole Woman's Health decision is that the Supreme Court now has 2 new justices? Would that factor into your
Well, the only thing
opinion?
that has changed is there are 2 new justices on the Supreme Court. Otherwise, it's still not a medically benefiting law. It still harms women. That has not changed.
Is there any meaningful difference in the current case that would warrant a different outcome from the court's decision just 4 years ago?
No, the law that's challenged is identical, not similar. It is identical.
I fear that the court's decision to hear this case less than 4 years after its decision has ramifications not just for abortion access, but for the impartiality of the entire court system. I'm disturbed by the implications of injecting ideology and distrust into our legal process. I'm really concerned about that. You know, you and I are lawyers, and when we take our attorney oath, you know, not only do we swear that we will represent our client zealously, but we will protect the integrity of the judiciary. We would hold public confidence in the court system, and I'm really disturbed about the implications of injecting ideology into the legal process. What signal does it send that the court is considering a factually identical case less than 4 years after the earlier case?
Well, we did ask for the court to take the case because the Fifth Circuit had not following their precedent. So we are hoping that the Supreme Court indeed does follow their precedent, because otherwise the floodgates will open to even more restrictions. States will know that anything goes.
And it will divide this country more than anything that we've seen in recent years, and I don't want to see that happen. Thank you, Madam Chair. You're back.
The gentleman yields back. A pleasure to recognize the gentleman from Virginia, Mr. Griffith, for his 5 minutes of questions.
Thank you very much. Ms. Colette, would H.R. 2975 eliminate state laws requiring a person to wait for a period of time between first visiting a provider and having an abortion?
It would.
Would it eliminate state laws requiring providers to obtain informed consent before an abortion takes place?
It would certainly limit what was required for informed consent.
Would it eliminate state laws requiring abortion clinics to meet certain medical standards?
It would.
Would it eliminate state laws?
Mr.
Yes.
Congressman, to the extent, like in Louisiana, where abortion clinics are regulated in the same way as ambulatory surgical centers, it might allow that since it is a general law.
Would it eliminate state laws that establish certain educational professional standards for those who perform abortions?
It could.
And would it eliminate state laws that have created licensing and inspection requirements for abortion clinics?
To the extent that they differ from many others, yes.
Okay. You know, I ask those questions because those are all things that I think are reasonable, particularly in many states, the 24-hour waiting period. And you have an active practice. When I was actively practicing, I counseled clients going into a divorce or other litigation. All right, here's where we're at. Here's what I would recommend. If you choose to go forward, go home and sleep on it. That seems to be very reasonable. Do you do the same in your practice? Do you think that's a reasonable request that people sleep on it before they make a final decision? Even on litigation, we're talking about something much more serious than that.
Just for purposes, if my dean is reading the transcript, I am a full-time academic with an active practice as well.
As well, right.
But yes, when I counsel clients, I started in estate planning, and when people wanted to file a will contest, I would obviously say, you need to go home and think about this and its impact on your family.
Right, because an estate fight means that the family may never get back together again, and there are going to be a lot of hurt feelings.
That's exactly right.
Here we're talking about a life. It seems very reasonable to me. Now, you and Ms. Northrop have got a battle going on, and she made comments earlier to straighten you out. Is there anything that you would like to respond to that she made in those comments?
Well, I just mentioned that unlike Texas, Louisiana's requirements are mirrored in their ambulatory surgical center requirements, and so that too makes the case unique.
Yeah. You know, it's interesting, the Virginia legislature this year is changing a lot of our laws related to abortion, but the Senate bill that was decided on a tie-breaking vote by the Lieutenant Governor Justin Fairfax does not eliminate Virginia's requirement for informed written consent. This bill would impact that possibly?
Again, the general requirement of informed consent could possibly be successfully defended, but specific types of information that would be required could be struck down.
Now, I'm going to ask you this one, and I'm not sure the bill directly deals with it, but I want your interpretation of it. Last year, there was a controversy in Virginia related to time of birth abortion. It came up as a result of the Kathy Tran bill. Would this bill make time of birth abortion available?
If I understand that phrase, I suspect it comes from the governor's statement that a child would...
Actually, it came from Tran's testimony. The governor went a step further to infanticide. The Tran bill actually didn't do that. It just said that if there was an emotional reason that a single doctor and the mother could decide to abort the baby even after contractions had begun and the mother was dilated and ready to deliver. Would this bill impact that in any way?
I have not considered that question, but it seems likely.
Would you be kind enough to consider it after today's hearing and let me know?
I would be delighted.
Thank you very much. I appreciate all of your testimony. I know this is an emotional issue for everybody. We're just trying to do what we think is right, and I yield back.
The gentleman yields back, and it's a real pleasure to recognize the gentlewoman from California, Ms. Matsui, for her 5 minutes of questions.
Thank you very much, Madam Chair, and I want to thank the witnesses for being here today on this very important discussion that we're having here today. First of all, Ms. Northrop, I want to, following up on the previous question, would you please clarify what you believe this bill would and would not do?
Yes, there's nothing in this bill that would change anything about the viability standard of the Supreme Court and the fact that post-viability, it is up to states to decide as long as there's an exception for women's life and health. So we've heard things this morning that suggest that this would do something else. Doesn't change Roe versus Wade in any way in that regard. What it does is simply say that if there is a regulation targeted just at abortion providers that is not medically justified, that it doesn't stand. Because that's what we've been dealing with. It's a very precise bill to address the fact that there's been this underhanded attempt to shut down clinics, block access to services with these pretextual bills.
Well, thank you very much for the clarification. I am particularly shocked by state laws compelling mandated speech for abortion providers. It is unsettling to me that policymakers are requiring doctors to give medically inaccurate, misleading counseling sessions before an abortion. It's difficult enough. Most concerning to me are state laws that mandate the inclusion of inaccurate information about mental health outcomes, such as post-traumatic stress disorder, anxiety, and depression, even though the evidence does not demonstrate that this is the case. The American College of Obstetricians and Gynecologists states that laws compelling physicians to provide patients with medically inaccurate scripted information are in direct violation of physicians' oath of care. Dr. Robinson, do you agree? In their written statement in support of the Women's Health Protection Act, the American College of Obstetricians and Gynecologists, ACOG, states that mandating medically inaccurate counseling manipulates informed consent and ethical doctrine rooted in the concept of self-determination and the belief that patients have a right to make their own decisions regarding their health. Dr. Robinson, can you describe what it is like for you to have to tell your patients medically inaccurate information?
Well, with my patients, it's already difficult for patients to make some healthcare decisions. And so complicating that situation and that interaction between me and my patients with requiring me to give them misinformation makes this even more complicated for the patients to make these decisions. And then I know that it's difficult for the patient sitting there to hear me tell them one thing and then go back and tell them medically accurate information, but tell them that my state requires them to do that. And if you don't mind, I just wanted to correct, or just to go back to this thing that we keep talking about viability. We talk about the child that President Trump brought on the stage about a week ago. The thing about viability is that is something that varies. We can't just put a gestational age on it. I know that he brought a child up that was allegedly 21 weeks and 6 days at that time. In 15 years of practice, I have never seen a 21-weeker survive. And, you know, as the healthcare committee, I think it's important for us to keep in mind that our job is to make sure that we make healthcare available for everyone. And one of those things that we have to think about when we're talking about viability is the resources of the area. If you have hospitals that don't have the resources to support a 23-weeker or a 24-weeker, I can't talk about a 21-weeker, I've never seen that medically happen, then they can't take care of these, they can't even begin to try to keep these children alive. The other thing about it is that as hospitals are closing, there's nowhere for these women to go. So one of the things that we can do to ensure health and safety for everybody is like looking at ways for states that didn't take Medicaid expansion to do that, so that these hospitals aren't closing at alarming rates.
Thank you very much. Dr. Robinson, in your professional opinion, is there any medical necessity for a mandatory delay between initial counseling session and the follow-up visit for an abortion? Yes
Absolutely
or no?
not.
Okay.
These women, when they come into my clinic, they've already thought about this long and hard. They put a lot of thought into this decision before they come through my doors.
Right.
And so to require them to wait an additional time frame only just puts an undue burden on them.
Okay, given this, do you believe that the Women's Health Protection Act is needed to ensure states cannot arbitrarily and unnecessarily restrict access to care?
Absolutely. My state went from having a 24-hour waiting period to a 48-hour waiting period. I can tell you I have never met a woman in 15 years who felt like the counseling that she received from me changed her mind about whether she wanted to have an abortion or not.
Thank you very much, and I yield back.
The gentlewoman yields back. I now recognize the gentleman from Florida, Mr. Bilirakis, for his 5 minutes of
Thank you,
questions.
Madam Chair. I appreciate it very much. In my limited time, I'd like to use this time to highlight pro-life voices in my district. Where appropriate, names have been changed to protect the privacy of the patients. I sincerely appreciate the faithful work of our nonprofit pregnancy centers like A Woman's Place, Medical Clinic, and New Life Solutions, and many others in and out of my district in the state of Florida, and the courage of my constituents to share their personal stories with our committee in order to better inform and guide. Sandy came to us having experienced multiple abortions in her past. She decided to choose life for this pregnancy. As a single woman, she needed support. She's been attending our Elevate class program during her pregnancy and receiving emotional and spiritual support. We also gave Sandy information about the Passages of Hope post-abortion recovery program. Next, we have our clinic staff recently met with a young college student who was unsure about whether she could be pregnant because she had been on birth control. She shared that the timing would not be good for being pregnant because of school and finances, and was emotional, even discussing how she could tell her parents. The father of the baby also shared concerns and said he did not feel he could be supportive of a decision to have a baby. During her sonogram, The client discovered she was very advanced in her pregnancy and left planning to find a late-term abortion clinic. Our clinic staff, these are the pregnancy centers, again, our clinic staff faithfully followed up with this vulnerable young woman who eventually chose life for her baby. She and the father signed up for classes and have been regularly attending, receiving love, encouragement, and support. And I have another constituent. She says, I am a pro-life woman. Her name is Cindy, in my particular congressional district in Florida. I found myself pregnant at 16 after a challenging childhood. I went to an abortion clinic to have an abortion because I wanted to break the cycle of generational poverty and abuse in which I have been raised. I didn't think I could do that while raising my own child. While in the clinic, I was struck by the fact that if my own mother, who had given birth to me at 17, had made the choice I was about to make, that I wouldn't exist. I couldn't go through with it, and I left the clinic. I thank God for that choice every day. My daughter will be 23 this month. She's about to graduate from college and will undoubtedly make a profound impact on the world. Having her changed my life for the better. I went to college and graduate school, and I have spent more than 20 years working in public service. My child deserved the same choice I deserved, the chance to live. Then we have Susan. Susan opened up to us and shared that she had a history of multiple abortions. She shared her circumstances and insecurities surrounding her current pregnancy. Susan said she was anxious regarding the father of the baby not being someone she was in a committed relationship with, and that it is her son's friend's father. She also shared her desire to find connection and that she had been feeling very lonely. She agreed to an ultrasound, revealing that she was past her first trimester. Although feeling overwhelmed, she decided to move forward with her pregnancy and enrolled in our Elevate class program for support and encouragement. Again, I have additional testimonies, Madam Chair, from Floridians that due to time constraints I was unable to get to. However, I ask unanimous consent, Madam Chair, for these voices to be included in the record. And I have.
We'll examine the documents and
Thank you very much,
circle
and
back
I
with
thank
you
the
for,
witnesses for their
submittal.
testimony.
The gentleman yields. Pleasure to recognize the gentlewoman from Florida, Ms. Castor, for her 5 minutes of questions.
Thank you, Madam Chair. Since we're in the Health Subcommittee, I'd like to focus on the health impacts and implications of medically unnecessary restrictions on abortion care and how they interfere with the important doctor-patient relationship. The American College of Obstetricians and Gynecologists notes that, like all medical matters, decisions regarding reproductive health care, including abortion care, should be made by patients in consultation with their providers and without undue interference by outside parties. Like all patients seeking medical care, women seeking abortion care are entitled to privacy, dignity, respect, and support. Dr. Robinson, please discuss the value of the doctor-patient relationship in the care that you provide, and how do waiting periods, inaccurate counseling mandates, criminal penalties on doctors, and other restrictions on abortion impact that doctor-patient relationship?
Well, the relationship that I have with my patients is one of the most intimate relationships that I have. A lot of times these patients come to me in critical times needing guidance, needing support, and one of the things that I can tell you that they don't need is judgment. And with some of the regulations that are passed, a lot of them are aimed at judging the patients, punishing them, and also punishing physicians. And this limits care, it limits options for patients. And As far as providers coming to the community, it also weakens the community because it decreases the likelihood of other physicians being willing to come and practice in those areas, especially hostile areas. I'm an obstetrician in addition to providing abortion care, and I see how this type of legislation is affecting the patients that I care for right now. I had a patient that was admitted to the hospital. She was pre-viable. She was not what has been recognized as the standard gestational age for viability, which is about 23 to 24 weeks. She was not that far along. And I saw that there was a physician who was co-managing this patient who was pushing this woman, focusing at that time more on the fetus and not on the patient in front of them. And so this young lady, she actually had preeclampsia, which is a pregnancy-related condition where her blood pressures were really high. She had systolic blood pressures that were greater than 200 and diastolic blood pressures that were greater than 120. We had tried to control her blood pressures with medication, but we do know that the only cure for preeclampsia is delivery. My hospital requires that I get consensus from another provider before I can proceed with doing what's best for that patient, which was emptying her uterus at that time. And I know as a medical professional that if I empty her uterus at that gestational age, her baby would not live outside of the womb, but that is what was needed. And I think that these type of restrictions and the threat of penalties to physicians, it affects the way we care for patients, and it further puts women in harm's way. And so this is going to add to the mortality, the infant mortality rates, maternal mortality rates that we're already seeing.
And that is a serious issue in America. Ms. Northrup, I've taken some notes on some inflammatory language here today. Abortion on demand, unlimited abortions at every stage of pregnancy, late-term abortion clinics. But that's not how abortion care works, is it? I mean, Roe allows for restrictions on post-viability abortions so long as they contain adequate exceptions to protect the women's life and health. Isn't that correct?
That is absolutely correct. It's the constitutional standard, and it's what's in the Women's Health Protection Act.
I mean, for over 50 years, Roe versus Wade has provided a right to privacy for women and families to make personal medical decisions. That was a landmark decision. It followed another very important decision that that said states cannot prohibit contraceptives, make that illegal. And these decisions have been fundamental to the well-being of women and families across America. Now we're dealing with politicians across the country who are mostly older men, let's be honest, in state legislatures and here in Congress. And they're enacting undue burdens on health services and contraceptives. And you have the Trump administration that wants to take away the protection for pre-existing conditions and eliminate health coverage, insurance coverage that covers contraceptives. States and some in the GOP have urged that doctors be subject to criminal penalties for necessary abortion care, have restricted what doctors can and can't say to their patients. That is dangerous, it's unsafe, and it's wrong, and that's why we need to pass the Women's Health Protection Act. So these decisions are made in consultation with physicians and not politicians. Thank you.
Gentlewoman yields back. I now get to recognize the gentleman from Missouri, Mr. Long, for his 5 minutes of questions.
Thank you, Madam Chairwoman. And I'm one of those older gentlemen that Ms. Castro was referring to. And the reason I'm older is because I graduated high school in 1973. 1973 was when they passed Roe v. Wade, as everyone knows, and I didn't understand it then, and I don't understand it now. And I don't make any apologies, but to think you can go in and take a human life, never registered with me as a high school senior, and as an old man, as Ms. Castro calls me now, it still doesn't register with me. Ms. Forney, I want to thank you for being here today and sharing your story and the work of Silent No More Awareness Campaign, which you co-founded. As you know, there's close to 20,000 women associated with this campaign, and many thousands have shared their stories about the emotional and physical pain of abortion. Can you speak to the common thread in these women's lives following their decision to get abortions? What are the physical and emotional aspects the women who've reached out to you go through?
Yes, thank you, sir, for asking the question. The common thread is that the belief we had when we were facing a pregnancy that was unplanned, unwanted, that somehow or another the abortion was going to solve it. The reality became, after the procedure was done, that it generated a trauma to us that created emotional and sometimes physical, and certainly just a sense of unease. A lack of self-worth often is a common way that we describe how we feel about ourselves. I think a lot of that, and this is just my opinion, but that we're designed physically to create life, to support life in our uterus and in our womb. And the idea that when we take those lives, it kind of goes against the actual nature of how we were created. So what the common thread becomes is that sense of regret, that sense of realizing that we didn't take the time to think about what we were doing. And we wish we would have, because now we look back and we recognize that the abortion didn't fix everything as we had hoped it would. We can't reset the clock after a pregnancy. We can't go back to being unpregnant. What we're dealing with now are women who have taken the lives of their unborn babies in the womb. And so living with that physical trauma of having an abortion happen to your body is physically traumatic. Then going through and seeing the emotional side of it, seeing other women pregnant, hearing a vacuum cleaner, these all become triggers that change how we can move forward. So that becomes the common thread. Thank you for asking the question.
Okay, you touched on my other 2 points there. Also going to ask you, you're also part of the Abortion Recovery Coalition. Can you tell us what this coalition is and what some of the programs are?
Yeah, it's really just an informal group of the different leaders, Save One, the Deeper Still Ministry, Surrendering the Secret, Forgiven and Set Free. We were all here in Washington last year for a meeting, and afterwards we got together and we said, gosh, we should keep meeting and having opportunities to, get to know each other better, get to know best practices of all these different ministries. And for Silent No More, we take all those ministries and we promote them as the healing resources that women and men and families can go to after they've had an abortion. So we really it's a very informal coalition. There's nothing, there's nothing more than a spreadsheet that created, a conference call, a set of conference calls that we have named ourselves the Abortion Recovery Coalition, but it's that informal, and I actually am the one who sends out the emails and hosts the conference calls.
Okay, thank you. And let me go to Ms. Collette for just 1 second in my last minute that I have here. But federal law and most state laws provide protections to individuals and institutions that consciously object to performing abortions, especially on religious freedom grounds. Does this bill maintain protections based on religious freedom?
It does not. It specifically refers to the Restoration of Religious Freedom Act and exempts this law from that. So the attack on providers of conscience will be swift and brutal.
Okay, and I had a little more, but I'm out of time, so I yield back. Thank you.
The gentleman yields back, and I now recognize the gentleman from Maryland, Mr. Sarbanes, for his 5 minutes of questions.
Thank you, Madam Chair. Thanks to the panel. Thank you to you, Ms. Alvarado, for your testimony, very powerful testimony, particularly towards the end when you talked about how we trust you to protect us when you deploy on behalf of the country, but yet some of these obstacles that are being thrown in the way of being able to have a safe abortion don't seem to trust your judgment to make what is a very deeply personal decision. And I think you conveyed that it's not one you made lightly. You thought about it. and you reached a judgment, and you made that decision. And the law of Roe v. Wade empowers you to make that decision, but your right to do that is increasingly imperiled by what we're seeing and what Ms. Northrup has described. And I thought that it might be helpful to have you just touch again on the things that, the obstacles you encountered, the things that you felt challenged your own judgment in a way that was kind of disrespectful. And then perhaps, Ms. Northrup, you could comment in each instance on how we're seeing that kind of roadblock or obstacle intensifying around the country. And at least three things that I think you touched on, Ms. Alvarado, that maybe you could talk about again was just limited accessibility and what that presented as a challenge to those services, the waiting period requirement, and then some of these very sort of customized, prescribed counseling or materials that you were required to review. So if you could just speak to that again, and then Ms. Northup, to the extent there's time, if you could maybe jump in and talk about why those sorts of things are an increasing problem that we're seeing across the country, which really, I think the sense on the part of many women is that rights that they thought were well protected and intact are now threatened, and that's generating, I think, a high level of anxiety across the country. So,
thank you so much. I would like to first discuss the 24-hour waiting period. There were many 24 hours prior to the mandated 24 waiting period that Mr. Griffith described. So there was that prior to the actual procedure, 2 separate appointments. Because of healthcare access in North Dakota, there's only 1 clinic, which meant that the 2 weeks prior to deployment, there weren't any open availability appointments for not only the first appointment, but the second appointment as well. This, as a law enforcement officer, these restrictions that were put in place made me feel unsafe. I had to travel 300 miles out of Grand Forks, North Dakota, to a location that I did not know, to undergo a process that I did not entirely understand or know how expensive it would be, and I told no one where I was going. These put me at greater risk. These restrictions are dangerous for women and only serve to reinforce stigma. I was also given scripted counseling, which has nothing to do with patient-centered care. It was scripted. It was not based on my needs or my body. And then on top of that, I had ultrasounds, 2 separate ultrasounds, 2 separate appointments. And again, none of that was patient-centered care. Those are obstacles to health care because abortion is health care.
Yes, and so the waiting periods that Ms. Alvarado talked about, 24-hour waiting periods, there's increasingly even 48 hours, even 72 hours, and they create a huge burden of travel on women and increased costs, time off from work, having to get childcare, and the like. She's also talked about the false scripted counseling, and again, we've been fighting those for years, doctors falsely having to talk about an untrue link between abortion and breast cancer, or between abortion and psychological issues, and now the new false counseling on medication abortion is reversible, which is not true. AMA is suing on that in North Dakota. And the forced ultrasounds, which are an insult to women. As the Fourth Circuit Court of Appeals found, it was a First Amendment violation to force doctors to perform an ultrasound and talk to the woman about the ultrasound against her wishes and needs.
thank you very much. I yield back.
The gentleman yields back. Chair now recognizes the gentleman from Georgia, Mr. Carter, for his 5 minutes of questions.
Thank you, Madam Chair, and thank all of you for being here. I want to talk about an area. Professor Collette, I'll direct this to you. I don't know if you've ever heard of Rankin, Georgia. It's in Effingham County in South Georgia. It's in the 1st Congressional District that I have the honor and privilege of representing. In Rankin, there's the Pregnancy Care Center of Rankin, and they offer a number of different services, including a free ultrasound to patients who are thinking about about having an abortion. And I had the opportunity, or my staff had the opportunity, to speak to one of the patients there. Her name was Paige. And Paige tells a story about how she was totally overwhelmed with what was going on. She was young, she was confused, and she was pregnant. And she visited the pregnancy care center and on the day that her abortion was scheduled and actually had an ultrasound. Paige ended up changing her mind and decided to keep the baby and not to have an abortion. And I mention this because, you know, this feeling of overwhelming uncertainty, I think, is certainly something that I would imagine happens to a lot of people in the same situation. So tell me how it is, in your opinion, Professor Collette, that a state that requires an ultrasound before someone has an abortion, that patients have a full understanding of their decision. How is that viewed as preventing a woman from accessing an abortion?
Thank you, Congressman. I'm very pleased to have that question because there does seem to be some misinformation on that fact. According to Contraception Magazine, a pro-reproductive rights peer-reviewed publication, over 90% of all abortion providers provide ultrasounds prior to abortions. They do so because, number one, they need to confirm that the pregnancy is intrauterine, that it's not ectopic, which is a major threat to women's lives in this country. It's one of the causes of maternal mortality. Number two, they need to confirm the gestational age because the gestational age of the pregnancy will determine what an appropriate technique of abortion is. For example, medical abortions or abortions using RU-486 are limited, according to the FDA, for the time period that they can be used, and in fact will be unsuccessful if used outside that time period in certain instances, and is terogenic, meaning it can cause birth defects. They also do an ultrasound in order to make sure, and the reason, I was just puzzling about why Ms. Alvarado had to have 2 ultrasounds, but it's possible either that because the North Dakota clinic did one in Minnesota, or the other possibility is that the physician was worried about fetal demise. If there has already been fetal demise prior to the abortion, then it's simply an evacuation of the uterus. And so in that instance, the emotional response to it will feel different. So ultrasound is something that any responsible care provider would do prior to performance of an abortion. Where the dispute typically is whether or not the woman, whether or not the view of the ultrasound should be positioned in such a way that the woman could see it, that whether or not it's in her field of vision or not. The woman, to my knowledge, under all of these laws has the right to look away, but that's really the question.
So in your view, this bill that we are considering, what would it mean to patient safety? I mean, when we talk about abortion services, and it's said that one of the safest medical procedures in the United States, yet in your testimony, you question the evidence used to back that claim.
That is correct, Congressman. Again, I would use the analogy of trying to regulate the tobacco industry based on the Tobacco Research Institute. The simple fact is, in this country, the abortion industry controls the research, and as the former editor-in-chief of the New England Journal of Medicine, one of the most prestigious medical journals in the country, has written in an op-ed regarding pharmaceutical research. When you have the industry controlling the research, a couple of things happens. Number one, research that results in negative information about the product simply doesn't get published. And number two, bias in the design of the research, bias in the selection of the question, all of that, bias in the interpretation of the results is a problem. If we're serious about women's health in this country, we need to fund independent, not industry-related research in this area.
I don't know how anyone could disagree with that. I have to adamantly agree with you. You know, it's obvious I'm pro-life, and I feel very strongly about it. My constituents and most of them are that way as well. So thank you for your work. Thank you for being here, and I yield back.
The gentleman yields back. I would like to give Ms. Alvarado a minute to respond to what Ms. Collette characterized relative to you. Do you think that what she said is correct about you and what took place? So you have a minute or less to respond to that, and I think it would be fair for you to do so.
Absolutely not. Ms. Collect was incorrect in her speculation of my story. Both ultrasounds were done at the Planned Parenthood of St. Paul, Minnesota. They were two separate. The first one is to verify the pregnancy and give a ultrasound picture, which I believe is purely to find out that I was pregnant and confirm that, but also in an attempt to shame the fact that I wanted these services. And I think that's what that law is there for, to have those two ultrasounds, not for any medical reason, but to reinforce the stigma of my choice.
Thank you.
Professor Collette pointed out that there were safety measures in this, that was possible. Is that not correct?
That is correct, and I also said that I was speculating. I was puzzled why she had two. Minnesota
Well, because
law
you were
doesn't require that.
speculating about someone else, I think
Fair.
that someone else at the table could clear the air on the speculation. That's why I called on Ms. Alvarado, so I don't think that that's out of order. I now would like to recognize the gentleman from New Mexico, Mr. Lujan, for his 5 minutes of testimony.
Thank you, Madam Chair. Last year, a U.S. District Court judge in Mississippi ruled that Mississippi's laws, quote, unequivocally, close quote, violated the 14th Amendment and found that the law demonstrated that Mississippi was, quote, bent on controlling women and minorities, unquote, and that the state professed interest in women's health was nothing more than, quote, gaslighting, close quote. Ms. Northrup, do you agree, and can you describe how abortion restrictions disproportionately impact medically underserved and minority communities?
Yes, and I'll begin by addressing the gaslighting comment of the federal district judge. That is what we have seen and established in case after case after case, that the purported interest of women's health is just a pretext for actually making it harder to access abortion services. And the reality is that most women in the United States who access abortion services are low income, and so the burdens fall heavily on them. And it is also the case that it is disproportionately women of color who have abortions, so these restrictions fall more heavily on them. And so the people with the hardest structural barriers to get abortion, to get good health care are the ones that these laws, which make it harder to get the health care, are falling on.
Dr. Robinson, recently Dr. Horvath Cosper, who is now a reproductive health advocacy fellow, said, I quote, if we're having to give people incorrect information and then saying, well, you know, the state requires me to say this, it's not actually true. It undermines the patient's confidence in us as providers. I know you touched on this in your testimony, but my question for you, Dr. Robinson, is what impact does it have on patients when you are required by state law to give them medically inaccurate information when some of your patients may already be distrustful of the healthcare system?
One of the biggest impacts is that it further pushes this stance that patients have where they feel like they're powerless when it comes to their health care. I mean, I'm their physician, I'm a healthcare professional, they're coming to me for help and advice, and then I have to sit there and tell them that I have no power over what I have to tell them. So it puts them and me too in a position where we feel powerless. And if you don't mind, I wanted to respond to the question about the ultrasounds and mandatory ultrasounds. There was a comment by Ms. Collette saying that it's used for us to determine gestational age, to decide what type of procedure the woman needs to have to make sure we rule out an ectopic. As a medical professional, I have other means of determining the gestational age for my patients. And I know how to do that and do it well. I learned that in my training at University of Alabama, Birmingham. I also have other means of determining whether there's an ectopic pregnancy. I can do that by my physical exam. And if I am unsure, then I'm responsible enough to know how to perform an ultrasound and make sure that patient receives that service prior to me proceeding. And then as far as determining whether there's a miscarriage or if there's already a fetal demise in performing that second ultrasound, that's not necessary because with a fetal demise, or what we would call a miscarriage, the patient still needs the same procedure. She's still gonna need a D&C. So that doesn't change anything. The woman is there, she wants her uterus emptied. If there is a fetal demise, she needs her uterus empty, and I'm still gonna do it the same way. It doesn't change my medical management at all.
Thank you. Look, what seems clear to me is there must be better access to health care for all Americans, especially the medically underserved, not further restricting access. And with that, I want to turn it over and yield to Ms. Kelly from Illinois. I'll tell you, there's been no stronger advocate that has been working on maternal mortality for people of color.
Thank you to my colleague, and thank you all the witnesses. With all due respect to my colleagues that are sharing stories about people that regret having abortions, I always find it so interesting that we tend to care more about the fetus than the adult or our children, because I worked on a maternal mortality bill for 3 years, and I could not get one person on the other side of the aisle to sign up for it until we made, some changes. And the biggest thing that we need, Medicaid expansion, and that's according to ACOG, no one has signed up. So I find it a little hypocritical, ranked 45th as far as women's health, and Louisiana is absolutely one of the worst, as is Indiana and Georgia. So can you talk about the connection between abortion restrictions and maternal health?
Well, it's the same patient population that's being affected by these abortion restrictions that are also affected by these other disparities in health care. We do know that when women can access health care early in their pregnancies, that they are more likely to have complications like preeclampsia, they're more likely to have preterm deliveries, go into preterm labor, and they're not able to access a medical professional until they go into labor, because at that point they can present to the emergency room and they can't be turned away because of EMTALA laws. But we know that they can benefit from care early on. So Medicaid expansion, making it more accessible for women to access the healthcare system before their time of need, even prior to pregnancy, would go a long way as far as decreasing these maternal and fetal mortality rates.
Thank you, Dr. Robinson. Gentleman, whose time was it? Oh, it was Mr. Lujan's. The gentleman yields back. Thank you. It's a pleasure to recognize the gentlewoman from Indiana, Ms. Brooks, for her 5 minutes of questions.
Thank you, Madam Chairwoman, and let me thank all of the witnesses for being here. I think it is very important for everyone to listen to each other, to your stories, to your legal perspectives. These are issues that this country and my state of Indiana has been grappling with for a very long time. I do believe and have tremendous faith in physicians, and we don't want patients to be powerless, but in my view, information is power, and having more information is power. And having, in Indiana, I think we have some common sense laws that provide those reasonable protections, both to mothers and to the unborn, all while making sure that mothers and doctors are well informed on their options and on the choices before them. In Indiana, doctors do have to provide mothers with basic information about alternatives to abortions, including adoption, providing assistance about being a mother before performing an abortion procedure. We don't ban abortions or tell mothers they can't make their own choice, but we do require physicians to have the responsibility to make sure that people do know they have a choice other than abortion. This bill, H.R. 2975, I believe, would restrict the ability of states to provide that sort of guidance to healthcare providers about these challenging discussions with patients. I'm also concerned that it would restrict the amount of information, which I do believe, again, is power for any patient, rules around, and Indiana's rules around late-term abortions. I'd like, while Ms. Northrup was asked by my colleague across the aisle, Ms. Matsui, clarifying what she thought this bill would do and would not do, I'd ask the other legal expert here at the table, Ms. Collette, would you please tell us what you believe H.R. 2975 would do and would not do?
I'm sorry. Thank you, Congresswoman. Based on the evidentiary standard, it establishes a clear and convincing standard for the state's responsibility to show that, in fact, the limitation or requirement significantly advances the safety of abortion. Given the lack of clear data on many of these things, that standard cannot be met. The Supreme Court has recognized clear and convincing evidence as the highest standard of evidence that we impose for civil matters. In addition to that, the definition of significantly advances is not defined in the bill itself, but there is a direction to the courts to provide the broadest possible interpretation of the legislation. And so it would override the Hyde Amendment, and it would override conscience protections that might find refuge in RFRA or state RFRAs. It is a bill that would essentially eliminate almost every state protection that are afforded women against the malpractice or misconduct of others. For example, I cite in my written testimony a couple of cases where the abortion industry has gone to court to avoid informing public officials where a young girl has been the subject of statutory rape, become pregnant, and had an abortion in that instance. I represented the Kansas district attorneys in a case where that was alleged on the part. They argued that the girl had a privacy right not to have the public officials, the law enforcement officials, know that she was raped. Those sorts of laws probably would fall as well.
Can you talk about Indiana law, for instance, requires parental consent for girls under the age of 18. Can you explain what some of the reasons are why states do put parental notification laws in place and why they've been found constitutional? And would this bill have any impact on that, in your opinion?
Those sorts of laws have been found constitutional where properly crafted. Many states have parental notification rather than parental consent. The court has only addressed parental consent in requiring a judicial bypass in cases where the girl's mature and well-informed, or in the alternative, it's not in her best interest to inform the parents. The reason the court has upheld these laws is because, number one, it's the common standard for almost every medical procedure that parents are involved in their minor children's decisions. So that's an important factor. But number two, they also recognize the benefit of the parent guiding the child in what the court calls the selection of an ethical and competent provider. Dr. Gosnell's been referenced earlier. There are cases in Louisiana that are part of the record in the case before the Supreme Court right now where providers have been operating without a license, where their license has already been taken from them. And so a parent would want to know that, and a parent would be able to help the girl with that. They've also found that the parents have responsibilities to those minors as far as support and for post-medical care. That's one of the biggest concerns.
Thank you. My time is up. I yield back.
The gentlewoman yields back. It's a pleasure to recognize the gentleman from Massachusetts, Mr. Kennedy, for his 5 minutes of questions.
Thank you, Madam Chair. I want to thank our witnesses for being here today, and I especially want to thank Ms. Alvarado for your service to our country that continues today, and also for your willingness to share your lived experience with all of us. Access to abortion enables people to decide when and if they want to have children. Limiting and restricting that access not only negatively impacts maternal health outcomes, but the more restrictions that are in place, the worse children's health outcomes become. These barriers impact educational levels for women and pregnant people, their ability to get better jobs, their ability to provide for their current children and families, their ability to be financially stable and independent. When we think about limiting access to health care, we need to think about the tertiary and unintended consequences that may come with it. Ms. Alvarado, there is one provider in your state, as you testified. Due to the time it took to see that provider, you were forced to travel to another state for care. You were forced to have a mandatory ultrasound. You were forced to wait 24 hours for a procedure, even though there was no medical rationale as to why. You were forced to have biased counseling about options that you were probably well aware of before you entered that exam room. You were forced to listen to lies about how abortion is dangerous. You face economic, physical, and emotional hardship just to receive access to health care as you defend our nation. Tragically, ma'am, your story is far from unique, because in this country, women and pregnant people are forced to be seen by a licensed physician, even though another clinician can perform an abortion service. Many people pay for an abortion out of pocket because insurance is restricted from covering it, as you testified. The federal government is no better. We restrict Medicaid from covering abortion services, again, basic health care restrictions. In no other circumstance would any one of these be acceptable, let alone all. But we put women, pregnant people, and their families in harm's way, and the repercussions negatively impact their emotional, physical, and economic well-being. So, ma'am, can you talk a little bit about how important it was for your economic security and personal future to access the care that you need?
Absolutely, absolutely. Thank you, sir. Like you said, a lot of these the information that they shared with me is information that I already knew. Information is not the only power. It's also about having access. Information and access are power. As soon as I knew I was pregnant, I had to think about the financial considerations of my life from that point forward and how it would change. I had seen so many barriers for women in the military, including childcare, continued deployment schedules, duty, and other responsibilities. At the time that I got pregnant, I was an E4 making $1,000 a paycheck, and out of that came rent, food, gas. And then
Can you, I didn't hear what you said your paycheck was. Can you restate that?
my paycheck was $1,000 every 2 weeks, and out of that came rent, gas money, food. And at that time, I already knew that I would be making a career outside of the military. So there were professional and educational aspirations that I had, and I knew that having a child and raising a child would require something completely different than I had planned.
Can you talk a little bit about, you mentioned this in your testimony, but just, I'll give you we have a minute and a half left, but so I want to get you to articulate, if you can, the burden and the honor that a nation puts on your shoulders to defend our country and the responsibility that you have with it, while also saying that you are not empowered to make these decisions over your own life.
Absolutely. I think the only word that really encompasses that feeling is infuriating. It's highlighting the hypocrisy that here I am in a position to change the lives of so many people in my chain of command and lead a 10-man team into a combat zone, but I was questioned multiple times and had to face multiple barriers in accessing health care that is so deeply personal to me.
And ma'am, do you think there's any logic as to why a series of politicians like those of us on these dais should be inserted between that decision between you and your partner, your family, your doctor?
No, sir. In fact, I ask that you continue to protect the fact that this is a decision, a deeply moral and ethical and personal decision that should be left to a doctor, a woman, and the people that she trusts most in her life.
Thank you, ma'am. Thank you for your service.
Thank you.
Yield back.
The gentleman yields back. Pleasure to recognize the ranking member of the full committee from Oregon, Mr. Walden.
Thank you, Madam Chair. Professor Collett, Section 4E2 of H.R. 2975 includes a list of exceptions, including one which states the bill does not apply to, quote, insurance or medical assistance coverage of abortion services, close quote. Now, a legal analysis by the Lozier Institute points out that since there's no definition of insurance or medical assistance coverage of abortion services, the bill may invalidate the Hyde Amendment, at least in certain situations. So my question as you read through that is, would you agree with that analysis that that section might invalidate the Hyde Amendment?
Congressman, it's quite possible, given the broad interpretation and the purposes of the bill, that a district court would rule that way.
And what other federal laws and policy riders do you think could be overturned by this legislation? I know you spoke to some, I think, with Ms. Brooks, but what other things would be overturned you're aware of?
Independent of the insurance aspect, I'm sorry, I misunderstood the question initially. I'm concerned that it will overturn things like the ultrasound law, like admitting privileges where there is a strong evidentiary basis, there is in Louisiana, things like requiring physicians to perform abortions. There are some states in which you don't even have to be a licensed medical professional to perform an abortion.
Say that again.
There are some states in this country where you don't even have to be a licensed medical professional to perform an abortion. It will also overturn things. Yes, Congressman.
That's amazing. I didn't realize that.
Yes, Congressman. And so there are also some, it will overturn limitations possibly on the use of RU 486. It will overturn certain informational requirements because abortion is, to my knowledge, the only surgery people, with the possible exception of vasectomies, that people seek out because of poverty, not because of a medical need for that particular surgery. It would overturn numerous other important safety regulations that women are protected by in this instance. And arguably, because of the health exception being undefined in the bill, it's possible that post-viability abortions would become essentially available at all times. Congress has received in the past testimony by abortion providers that they believe that a woman who is psychologically distressed with her pregnancy has a health condition that would justify a post-viability abortion.
And define in layperson's terms post-viability abortion.
Post-viability is an abortion that occurs where the child could safely be delivered and surrendered for adoption. Instead, the abortion provider actually goes forward and terminates that child's life.
And how late in the pregnancy can that occur?
As this committee has already heard, the standard age right now is accepted in the medical community is 23 to 24 weeks, although we do have some cases in which children before that have successfully survived.
Right. And do you know off the top of your head what states don't require licensed medical providers to provide abortion?
Vermont is an example, I believe, Your Honor.
Okay,
I'm sorry, Congressman.
Yeah, we're not
I'm
judges
used to
up
court.
here. Yeah, thank you. Ms. Forney, in your testimony, you mentioned a Planned Parenthood clinic in St. Louis that had its license revoked due to safety concerns. Can you elaborate on that? Why was its license revoked? Please turn on your mic, if you would. Thank you.
There were 75 medical emergencies that were documented at the RHS Planned Parenthood abortion facility. And then there was a new facility that opened across the river in Illinois, and in October of 2019, another incident occurred. The facility in Missouri has had numerous visits by ambulances taking patients out. I was there a couple of years ago, just on a Saturday morning praying with some folks, and we had an ambulance show up. I was shocked. I had never seen an ambulance at an abortion clinic, and the normalness with which it was treated was very concerning.
Can you speak to the specific safety issues that were identified that caused the license revocation?
Well, in the specific issues related to the license being revoked had to do with 4 women, 4 individual women specifically, that each experienced a major complication. And that's what brought this to the attention of the state authorities.
My time's expired. Thank you all for your testimony, and Madam Chair, I yield back.
The gentleman yields back. It is now, let's see, who's next here? The chair recognizes the gentleman from California, Mr. Cardenas, for his 5 minutes of questions.
Thank you very much, Madam Chairwoman Eshoo, and thank you also to Ranking Member Burgess for having this important hearing today in the Health Subcommittee. I think it's so important for us to understand that listening to the impacts of these unfair and unnecessary and stigmatizing restrictions on women across our country is very important for us to discuss and for the American people to hear. My daughter Alina happens to be with me today, and she reminds me that nothing is more personal than choices about family, including how and when to have one. That is true no matter your zip code or the number on your bank account. I have been blessed with an amazing family, and at the same time, I have never had to experience a pregnancy, me personally, or any other complications or any other matters that a human being has to go through to have a pregnancy. I've never had to worry about becoming pregnant or face the health implications as a result of that. As a man, my health care is not picked apart and politicized because of judgments that lawmakers have about my personal circumstances or decisions. This is one of the many reasons that it is so important to listen to women, to truly hear their experiences, to follow their leadership on all of these issues. All the men in the world need to speak less and listen more. I'm a proud co-sponsor of the Women's Health Protection Act, and I'm so grateful for the leadership of Chairwoman Eshoo and all the other members who've signed on. I have a question to Ms. Northrup. Ms. Northrup, are you aware of any laws in our country
in the United States of America that require a man to sleep on it or to think twice about a medical procedure that they choose to take, specifically to men?
I'm not aware of any such laws.
Okay, neither am I, and I've asked some of my colleagues who are very involved in many issues, and they just shake their head and say, no. As a matter of fact, I'm not aware of one. But yet here we are speaking about laws across the country and legislatures across the country that, in my opinion, have proven over and over and over to violate the law of the land and the Constitution of the United States. At this time, I'd like to yield the balance of my time to my esteemed colleague, Ms. Congresswoman Schakowsky.
Thank you so much for yielding. Ms. Collette, I just have to say how much I resent when you say, if you really wanted to care about women, you would do something about prenatal care, or you would do something about maternal mortality. Women, on this side of the aisle anyway, have been working so hard to do exactly that. And the implication is very offensive to me that somehow we are blocking addressing these issues. And the idea of abortion, the abortion industry is controlling the data. Abortion industry. Do you mean like ACOG, the American, what is it exactly, Dr. Robinson, ACOG?
American College of Obstetricians and Gynecologists.
Yeah, that industry, and they support this legislation. I want to talk to you, Dr. No, I'm not asking a question. I'm telling you how you make me feel with the kind of testimony you've given. So I just want to say to Dr. Robinson, so your home state of Alabama openly is hostile to abortion. You said that you have to give false information. How do you get around? So then do you say, but the truth is, how do you deal with that?
Well, I basically waste my time and my patients' time to give them the information that the state requires that I give them, and then I go back and tell them true medical facts based off of my training and experience. And there's this concern expressed around if this Women's Health Protection Act is passed, that patients won't get informed consent. We are trained as medical professionals to give patients that anyway. We don't need politicians to tell us or to dictate exactly what is told to a patient in the room. As an abortion care provider, I can tell you without a fact, I am not ashamed of any of the care that I provide, and I'm not scared to tell my patients the facts about the services that they're there to receive. And these patients are under no delusion about what service they're there to
Let me just ask you one more question, though. Are you in danger? We have heard about people who provide care, including abortions, being under attack and even worried about their physical danger.
Absolutely. My physical person is in danger at times, and also my financial stability in my community, because my hospital sometimes will make it difficult for me to remain in the hospital and maintain hospital admitting privileges, because sometimes they just may be opposed to having an abortion provider on their staff, but they are harassed and the facility is picketed. And as far as my physical person, yes, I am in danger when they talk about abortion providers
Dr.
performing
Robinson, the
infanticide.
gentleman's time has expired. I always hate to cut people off, but I've been generous on both sides of the aisle, and witnesses from both parts of the both sides of the issues that we're discussing today. It's now a pleasure to recognize the gentleman from Montana, Mr. Gianforte, for his 5 minutes of questions.
Yeah, thank you, Chair. While my colleagues on the other side of the aisle seek to further undermine the rights of the unborn with this legislation, I want to tell a story about a young woman from Montana and her beautiful baby boy. For the sake of this story, we won't use her real name. Instead, I'll call her Amy. When Amy was in her early 20s, she took a home pregnancy test. When the result proves positive, she thinks long and hard about her options. Amy's a kind-hearted woman who, in her own words, wouldn't hurt a soul, but is now weighing abortion as an option. Afraid of the unknown, her reasons for considering an abortion grow.
The next day, Amy walks into a clinic to get another pregnancy test to verify the result of the night before. The results are confirmed, and an ultrasound indeed shows that she's carrying a 6-week-old child. The fears from the night before resurface. Through her tears, she asks a nurse, "What am I supposed to do?" as the weight of the decision comes crashing down on her. Comforting her, the nurse says, "Just give it 24 hours. Don't make any final decisions for at least a day." Amy waits a day. Then she waits another. 12 days later, she schedules another ultrasound and signs up for parenting classes. She decided to keep the baby. The advice to be patient that nurse gave allowed Amy the time she needed to realize her fears were just that, only fears. For her birthday, on May 20th, 2019, Amy gets what she will tell you is her greatest birthday gift ever: a happy and healthy baby boy. Amy's story is one of hope in the face of fear that acts as an inspiration for all of us. If it weren't for the nurse who counseled patients, it's a story that would have ended very differently. It's stories about nurses and clinics like this that I'd like to hear more about from our esteemed witness, Teresa Stanton Collette. Professor Collette, H.R. 2975 states that pro-life laws, quote, harm women's health by reducing access to other essential healthcare services. My question for you is, what options besides Planned Parenthood are there for women seeking comprehensive healthcare services?
There are multiple resources, including some that are federally funded. So during the debate, I believe, over the contraceptive mandate in courts, since that was actually a regulation of an agency rather than a congressionally mandated situation, it was established that contraception is readily available to women throughout the country. I think at the time the cost of the pill was $10 and something at Walmart. So first, you have all sorts of general clinics that'll provide that. Increasingly, even some of the doctors at some of the new models like urgent care are providing that sort of contraception access. Sexually transmitted diseases, also that testing is available. Usually the Department of Health in a state will have some clinics that are available to people as well.
Okay, so suffice to say, women have options beyond Planned Parenthood.
They absolutely do, and better options.
Okay, thank you. And why would you say they are better options?
Because Planned Parenthood, although it does report that a few of its locations offer adoption services, the actual numbers that are revealed in their annual report show that that's not an option that they actually proceed with, nor do they provide prenatal care beyond the most basic during the first trimester, whereas many of these other clinics will provide obstetric care throughout the pregnancy as well.
Okay. In the last series of questions, my colleague, Ms. Schakowsky, addressed some comments to you. Is there anything you'd like to say in response?
Certainly. The American College of Obstetricians and Gynecologists has never taken a position against abortion or recommended any regulation. There is a brief that's been filed in the Louisiana case that specifically gives the history of how the American College of Obstetricians has become politicized on this particular issue.
Okay. Thank you for your testimony. With that, I yield back.
Gentleman yields back. It is a pleasure to recognize the patient gentlewoman from Michigan, Ms. Dingell, for her 5 minutes of questions.
Thank you, Madam Chair. I sort of have two different ways that I want to go because I want to talk to Ms. Alvarado. I want to say that this is a deeply personal issue for every woman. And we've seen and heard that today from the advocates, the providers, and the woman. I'm somebody that believes that these decisions are best made by the individual woman and her doctor. We owe each woman to treat them with trust and with dignity and to uphold that principle. Having said this, Ms. Alvarado, we all thank you for your service, no matter, I think there is nobody at this table that isn't grateful. And I'm looking at the pain in your face today, and I know how hard it has been for you to come and testify. But before I get to you, I'm going to do two things you're never supposed to do. First of all, Ms. Go off script. Ms. Collette, and I know everybody here cares deeply. So, but when you say that this procedure is the only one that you know someone gets because of poverty, last week I was with a 24-year-old woman who had been diagnosed with breast cancer and chose to have a double mastectomy because she couldn't afford her chemotherapy. So I think what too many people don't understand is that the number of women that have no option. In parts of my state, Flint, by the way, being one of them, the only place women who have no desire, they just need health care, the only place they can go is Planned Parenthood. Ms. Thorpe, I heard you listening carefully to what she said. Is there anything you would want to add?
Well, I would like to respond to the characterization of this bill, which I think that Ms. Collette has not properly characterized. And again, I appreciate that we differ here about whether or not abortion should be safe and legal and a woman's decision. But what I don't appreciate is mischaracterizing, and I've been doing this for 17 years, leading the center, and over again, we're trying to, use these proxy fights. This bill is very targeted at the problem of unjustified medical burdens on clinics and patients that are not justified by medicine and science. It does not upend the Hyde Amendment. The Hyde Amendment is an unfair restriction on low-income women's access. There is a bill, the Each Woman Act, which importantly addresses that. This bill clearly excludes in its language, and that language is not tricky. It's very clear that it's not just Hyde, it's any kind of insurance that doesn't cover it. It was also suggested that doctors are going to have to provide abortions and that the objections that doctors can now make because they don't want to provide would be upended. That's not what this bill does. It's also been suggested that it's going to allow abortions at times that Roe versus Wade doesn't allow abortions. That's not what this bill does. It adopts the Roe standard. It is very targeted to address a problem at this moment, which is 450 laws that are shutting clinics, blocking women's access. And I just think it's important to debate what this bill does and not to confuse it with things that aren't true.
Thank you. Ms. Alvarado, thank you again for your courage. And I had many questions, but because I wanted you to talk about your personal experience, but I'm going to ask you this. Ms. Collette states in her testimony that there's little, if any, link to reproductive health care access and a woman's economic well-being. Do you feel that this is accurate given your life experience?
No, I'm able to live the life that I live now because of the decisions I made at 22. The access, I'm sorry, how do I say this? I had to travel outside of my state with balancing many restrictions and trying to pass those in order to make a safe healthcare decision for myself. And that decision has now led me to the life that I live now. I was able to complete an education, working in a beautiful career, and meet my partner. And that was all because I was able to make a safe decision for myself.
What would you say to the state legislators that are passing these laws from your own personal experience?
That their philosophical beliefs and these restrictions that they impose on women are not for the women at all. These are only obstacles to health care, and women deserve to make the best choice for themselves.
I yield back, Madam Chair.
The gentlewoman yields back. I now would like to recognize the gentlewoman from, no, that's not right. Do we have?
No, that'd be South Carolina, ma'am.
Well, let me just note that we have, I think, just one member left here that is waving onto the committee. But because you're not a member of the subcommittee, we need to take all the subcommittee members before you. And then I'd be glad to recognize you, Mr. Duncan. So the gentlewoman from Illinois, Ms. Kelly, is recognized for her 5 minutes of questions.
Thank you again to the witnesses for being here today. Due to restrictions
on access to abortion care, many women must travel long distances, furthering delaying their access, as we've heard today, to care and increasing their risks to their health. As various states seek to decrease access to care by implementing harmful restrictions, many women must cross state lines to places like where I live in Illinois to receive care. It should not be difficult for women to have access to the constitutional care they need and are entitled to, and I'm proud that my state has trusted women to make these decisions for themselves. I want to talk about the implications of abortion access on women's long-term health. When access to abortion is restricted, we know there are negative health outcomes that can result, harming communities who already face the most challenges to accessing care, as we've heard already. A groundbreaking study from the University of California, San Francisco, found that women who are turned away from accessing abortion and forced to carry an unwanted pregnancy to term are almost 4 times more likely to live below the federal poverty line. Ms. Northrup, are you familiar with this study?
The study from USC? Yes.
Can you
UCSF?
describe the findings of the study and what it means for women's long-term health outcomes?
Yes, and we have cited this in our submitted testimony, that the study that looked at women who were turned away, who were unable to access abortion care, that they had higher incidence of being in poverty, that they had higher challenges with meeting their basic needs in terms of housing and other economic needs, and that they did not have, that overall, when they looked at women turned away or not turned away, the issue about psychological health was not impacted on the women who were able to access.
And also, is my understanding that women who are unable to terminate unwanted pregnancies would stay with violent partners longer, putting them and their children at greater risk.
That's right. It was a very important finding of the study that women were more likely, if they were turned away, to stay with violent partners.
And we just discussed the impact on economic security. And I, again, want to thank you for sharing your story with us, and you, Ms. Fournier, for sharing your story, and Dr. Robinson for sharing your story. I know it's not easy, and I want to say something about myself, that I'm a pro-choice person that is pro-life. You know, the thing that either you're, you know, pro-life or pro-choice. I'm pro-life, but I believe in choice. Thank you. I yield back.
Gentlewoman, yield the remainder of her time to me. I appreciate it. I think it's very important to set down, first of all, to Congresswoman Kelly, the UCSF study I raised in my opening statement, and it's wonderful that you highlighted it and underscored it again, because it contains very important information. I think it's important to set the following down as part of the record here. Studies show that contraceptive access is responsible for 1/3 of total wage gain women have made since the 1960s. And while I found your response, Ms. Collette, to I believe Mr. Butterfield asking you if you believed in contraception, and it was interesting for you to share with us that you are post-menstrual, you didn't answer the question. Contraception is one of the answers to what is problematic in our country. And there is an entire movement against contraception. There is. When the Republicans were in control many years ago, they removed, with a House vote, contraception coverage in the health care coverage that members of Congress had. It was corrected later on. So I think it's very important to put that on the record. And reproductive choice is vital for women to have economic freedom. It's a choice that they make. It's not forcing them to do one thing. They have a choice. It can be a spiritually, in the lane of spirituality. It can be many things, but it is a choice. And so the whole issue, I think, that has been, some of our witnesses refuse to talk about contraception, but I think that it is really in the center of this discussion in this debate. I now would like to recognize the gentleman from California, Dr. Ruiz, for his 5 minutes of questions.
Thank you very much. A 2019 article in the journal Obstetrics and Gynecology described the consensus guidelines for obstetric and gynecological care in the United States and brought together a broad group of clinicians, consumers, and representatives from accrediting bodies to review the available evidence and clinical practices to develop an evidence-informed policy. The report concluded that, quote, requiring facilities that perform office-based procedures, including abortion, to meet standards beyond those currently in effect in all general medicine offices and clinics is unjustified based on this thorough review and analysis of available evidence, unquote. I would like to request unanimous consent to submit this article for the record. Indeed, the authors noted that, quote, false concerns for patient safety are being used as a justification for promoting regulations that specifically target abortion, unquote, and that, quote, targeting specific procedures based on ideology rather than evidence sets a dangerous precedent for the regulation of medicine, unquote. Dr. Robinson, are you familiar with this article?
Yes.
It seems clear to me that the restrictions on abortion care placed by some states, presumably under the label of, quote, safety, are not actually based on evidence or clinical guidelines. Would you agree?
I agree, that's correct.
Okay. What precedent does it set for medical standards not based on any evidence or clinical care guidelines to be imposed on medical procedures?
Well, one of the things that we do see is that it reduces options for patients. It sets a standard where me, for instance, as an obstetrician gynecologist, I can't offer all options to my patients because it's being restricted according to political interference.
And so you agree with the journal authors that this sets a dangerous precedent for the regulation of medicine?
It does.
How does that influence outcomes in patient care?
Well, if politicians or regulations like this are dictating what we can do as providers, then it puts patients' health at risk. It takes options that are viable options that are really pertinent for a patient's health care. It takes them off the table. I talked earlier about one of the patients that I took care of in the hospital who, because of these regulations, abortion care is very restricted in our hospital. A patient who needed to have an abortion, and sometimes these patients, they present to our outpatient clinics, but they really need inpatient care. I don't have that option, and these regulations only limit it more.
According to the authors of this journal article, the panel of medical experts found that abortion procedures should be treated the same as comparable medical procedures in primary care and gynecology based on medical evidence and expert-driven clinical guidelines. It's what we do in medicine. I'm a doctor. It's, you know, you have your peers review what's best in terms of evidence given the experts' recommendations to produce these guidelines. Do you agree? And if so, can you discuss with the committee why you feel this way, that abortion procedures should be treated the same as comparable medical procedures in primary care and gynecology based on those that evidence?
I think the best way to highlight that is to look at some of the examples that we've talked about today. Because we're not treating abortion and contraception in the same way that we're treating other areas of medicine, we're seeing clinics close. For instance, Planned Parenthood clinics that serve a lot of patients that do more than just abortion care. They provide contraception. Many women go there for just their preventative health services. And because of the way we look at abortion and contraceptive care here, we have Planned Parenthood clinics that can no longer take care of patients that receive state funding, like Medicaid funding. And I know that Ms. Collette, she mentioned that you have federally qualified health centers and urgent cares that can see these patients. The one thing about it is a lot of these centers are not looking at the patient populations that centers like Planned Parenthood are serving. There's a lot of urgent cares in my area that will not see a patient on Medicaid. So if you have commercial insurance, you can go, or if you're paying cash, you can go. But those patients who are already financially underprivileged, they don't have the option to just go there and pay cash. In urgent cares, a lot of them don't take Medicaid. So the reality, what you're talking about is not the reality in real communities. And so this legislation is hurting real patients.
Thank you.
Those patients who would previously be served by a Planned Parenthood location.
Thank you for your work. Medical decisions should be made on the basis of science and evidence, not on the basis of politics and ideology. That is why I support the Women's Health Protection Act and urge my colleagues to do so as well.
Thank the gentleman. His time has expired.
If I may, just to submit this for the unanimous consent for the record.
We have that for the record. Thank you. The chair recognizes the gentlewoman from California, Ms. Barragan, for her 5 minutes of questions.
Thank you. I want to thank the panel for being here. Ms. Alvarado, I want to thank you for sharing your very personal story with us, for your testimony. That was just very moving. This issue is very personal. I'm the youngest of 11 kids. And when I was very young, my sister, one of my sisters got pregnant at 15. And my other sister got pregnant at 16. And my third sister also got pregnant at a very young age. And two of my sisters, one at 15 and one at 16, made a very personal decision to give birth. My third sister made a very personal decision that it wasn't time for her, and she wasn't ready. And it was an important life decision that all three of my sisters made. And if I talk to them, they'll tell you how grateful they are to have the ability to make a choice. And so you coming forward today and sharing your story is not easy. Because when I've had this conversation with my sisters, they've told me that it wasn't easy. And so having you here today means a lot, because I believe it's important that other women, regardless of age, but especially our young people, hear from people like you. And I just want to give you an opportunity, if there is anything that you want to add, based on your own personal experience or perspective, to emphasize why it's important that we hear from people like you and people like my sisters talk about the issue of reproductive health care and the importance of having a choice.
Thank you so much for sharing as well. If I could just address that my story of no regret and the story that Ms. Forney shared of regret, they live in the same world, they coexist. And I'm only sorry that those individuals that regret their abortion were not empowered to make the best choice for themselves. And at the heart of that is choice. Of the women that do have an abortion, 95% of those women do not regret their abortion. And I am part of that majority. And I think that the only way moving forward is to trust and empower women by giving them access without restrictions.
Right. Well, thank you. I also, Dr. Robinson, want to thank you for bringing up Planned Parenthood and clinics that are just so critically important, especially in communities like mine. I represent a district in South Los Angeles that includes areas like Compton and Watts. There's only 4 districts that are poorer in California than my district. And when I was a child, after seeing my 3 sisters go through what they went through, I decided that I would have to find a clinic, much like a Planned Parenthood. Back in those days, we looked through the yellow pages, and I found a clinic. And I'll tell you, I was afraid to tell anybody that I was even going to go seek advice on what options there were. But I remember walking in, and I remember being welcomed and being told my first question was, how much is this going to cost me? I didn't have a lot of money, and I was told it was a sliding scale, and I didn't have to pay. But it was just so important as a young person to have that opportunity to go and get access to health care. People think, oh, well, there's health care everywhere. You can go wherever you want.
there's many people in low-income communities and communities of color that don't have the access to health care. And access is something that we've been fighting for. And it's not as easy as going to wherever you want, especially not when you're 14 or 15 and you just want to go get advice and get some guidance. Dr. Robinson, we've talked a lot today about how trap laws are medically unnecessary requirements imposed on abortion providers and women's health care centers. Can you maybe elaborate a little bit on the hardships that low-income women must face in states that have the trap laws?
Well, we know that forcing women to continue a pregnancy, that is just kind of a basic violation of a woman's basic humanity, her rights, and her freedoms. We know that when women can't access the health care that they need, be it an abortion or contraception, that it can further push them into poverty. And there's good studies that support that. It's not just our opinion, that's the absolute fact. It's just really important for patients to be able to access the care that they need in a timely fashion, and that women should be able to access the care they need in their community. And these trap laws is making it difficult for them to do that.
Thank you. The gentlewoman's time has expired. I now recognize the gentlewoman from Delaware, Ms. Blunt Rochester, for her 5 minutes of questions.
Thank you, Madam Chairwoman, and thank you to all of the witnesses, to my colleagues, all of you who have shared your stories. This is a very personal conversation as well as public, and I was sitting here thinking, I am a daughter, I am one of 3 sisters, and I am a mother of a 31-year-old and also a mother-in-law. And it is surprising to me that in 2020, we're still having to fight for this right. I really appreciate the fact that we're having the conversation. I really appreciated also hearing from the men who spoke up and shared their perspectives. I come from a state, the state of Delaware, that has been a leader in protecting women's health and safety. In 2017, Delaware passed a law recognizing the constitutional right to abortion. But instead of seeing more states across the country expand and affirm abortion care and access to comprehensive reproductive health services is being delayed and obstructed by harmful and medically unnecessary barriers. Every American deserves the freedom to make personal decisions about their health and their future. I really appreciated what you said, Ms. Alvarado, about the fact that these stories are, really 2 sides of the same story, and that the piece that I think links them together is that choice. We must pass the Women's Health Protection Act to safeguard abortion care and the ability for an individual to make personal decisions with fairness, safety, and respect. And I know there was conversation about speaking for those who can't speak, but there were many women who came before us who had to go in back rooms and alleys and have things done to them that were unsafe and unhealthy. And they had to either live or perish with the consequences, which is why what we're talking about today here is so important. I'm glad we clarified some of the aspects of the bill, and Dr. Robinson, I really appreciated your bravery as well and your continued strength. Earlier this month, an individual in Delaware defaced our Planned Parenthood with an explosive. Thankfully, no one was hurt, but the incident shows that there can be personal safety risks for physicians and staff who provide or speak out to protect access to abortion care. So again, I want to thank you for being here, and really in a little bit of time I have, I just want to ask you if you could talk about how Alabama's law has forced you to practice substandard care and what stigma has meant to your patients.
Well, the law has forced me to practice substandard care or do things that I would not normally do, in the sense that, like I said, sometimes I have patients that present to our clinic that if I had my choice, they would be taken care of. Their abortions would be provided in a hospital setting. This may be women who have, for example, like very low hematocrits. They have a history of any type of bleeding disorder, where they're on blood thinners. We need to take them off that medication for a period of time to be able to perform their procedure. If I could take care of them in the hospital, we could reverse their blood thinners in the hospital setting and take care of them and then get them started on their medication again. Patients who have a low hematocrit sometimes would be served better by being taken care of in a hospital. When I say low hematocrit, I mean a low blood count, because there's a blood bank available in the hospital where they can access the resources they need if that becomes necessary. I don't have that available to me in my clinic setting, but these women still need abortion care. We have many women who have had multiple other abdominal procedures, like multiple cesarean sections. Our C-section rates are really high. And these women, when they present for abortion care, sometimes there's concern about the placenta being very adherent to the previous surgical scar. These women sometimes would be served better by being taken care of in a hospital setting, but I don't have that choice. So I have to give them the very best care that I can in my clinic setting. This is the only area of medicine where it's like a zero-sum game. You can't have any mistakes or any mishaps, but sometimes these patients may suffer complications in an abortion clinic and need for me to call an ambulance for them. That does not mean that we didn't provide good care. It just means that I was forced to care for them in a setting that I didn't choose.
Thank you, Dr. Robinson. My time has expired. I thank the gentlewoman. We'll now hear from two members that are waving onto our subcommittee today, and I'll call on and recognize the gentlewoman from New York, Ms. Clark, for her 5 minutes of questions, followed by the gentleman from South Carolina, Mr. Duncan. Is Duncan goes? Oh, we just had a Democrat. Mr. Duncan, you're recognized. The gentleman from South Carolina, Mr. Duncan, is recognized for 5 minutes for his question. So welcome to the subcommittee.
Thank you, Madam Chair, and thanks for allowing members to be waved on. I want to thank the ladies on the panel today for your stories. A lot of them are very, very touching. And I have 5 stories from the Carolina Pregnancy Center in South Carolina I'd like to submit for the record. Thank you. I am a author of the ultrasound bill. I believe that requiring a woman to look at an ultrasound could save the lives of many, many babies. As a father of 3 sons, one of which was born very premature, I saw the ultrasounds of my boys. Saw the heartbeats, saw the little legs and arms kicking. And I'm an evangelical Christian, a sinner saved by grace. And I want to read some scripture because as a Protestant, I've studied the Bible not nearly as much as I should. But I do know that in Psalm 139, verse 13, it says this, speaking of God, "For you formed my inmost being, you knit me together in my mother's womb." Job 10:11, "You clothed me with skin and flesh and knit me together with bones and sinews." Psalm 119:73, "Your hands have made me and fashioned me. Give me understanding to learn your commandments." Ecclesiastes 11:5, "As you do not know the path of the wind or how the bones are formed in a mother's womb, so you cannot understand the work of God, the maker of all things." Isaiah 44:24, "Thus says the Lord, your Redeemer who formed you from the womb. I am the Lord who has made all things, who alone stretched out the heavens, who by myself spread out the earth." See, in Genesis, God says, "Let us make man in our own image and our likeness, after our likeness, and let them have dominion over the fish of the sea, over the birds of the heavens, over the livestock, and over all the earth, and over every creeping thing that creeps on the earth." Genesis 1:26. What that tells me is that as we're being stitched together in our mother's womb, we're created in God's image, and that God is in the womb as well. And when that baby, that little boy or little girl has his life taken in the womb, God is in there, present for that murder. Scripture says we're made in the image of God. Are we made in the image of God while we're stitched together in our mother's womb, or after we take that first breath of life? When does that happen? To me, it happens at conception, because God knows me, knows us as we're there. I guess I'm here today to speak on behalf of the little boys and girls that are killed in the womb as those forceps are reached in and that back of the neck is pinched and brains are sucked out, parts are pulled apart. Somebody's got to speak for them. Those are human lives. Now, I'm not going to sit here and say I understand what a woman goes through, because I don't, but I understand what a father goes through. I understand what a father goes through who had a premature son who was in an incubator and I couldn't get my hands on him to hold him, and how my arms ached wanting to pick up my son and hold him, not knowing whether he was going to live or die. Because at that point, when you're in the neonatal intensive care unit, you don't know. But I'm not going to profess to know what the women feel. But the little boys and girls in the wombs, they're feeling pain. We can kid ourselves that they're not. But they're human lives and they feel pain. Ms. Forney, I wasn't present for your story earlier, but my staff told me. And I want to thank you for that. One quick question in 19 seconds. If a woman is required to look at an ultrasound, do you think more lives would be saved?
Absolutely. Data proves that out.
Ms. Collett, if a woman has to look at an ultrasound, do you think more lives would be saved?
I think the data is not conclusive on that question. It depends on where the ultrasound is performed.
Thank you all for being here. Madam Chair, thanks for being waved on. I yield back.
I would like to revisit something. I didn't catch what you said that you would like to place in the record. Can you? We'll review it. Thank you very much, and thank you for joining us at the subcommittee. We have, let's see who is next. The gentlewoman from New York, Ms. Clark, is recognized for her 5 minutes of questions.
Let me thank you, Madam Chair, for giving me the opportunity to wave on today. As Vice Chair of this committee, this is a very, very important subject matter that we must confront in the 21st century. We have a constitutional law. And at the end of the day, we're still engaged in a debate that pulls at every one of us. Let me say that I'm in full support of the Women's Health Protection Act. Full support, full stop. The first Planned Parenthood facility was opened in my district, Brownsville, Brooklyn. That's right. And I believe in choice. The choice is whether you want to bring a life into this world and your circumstances support that, or the choice to have abortion care because your circumstances demand that. And when we get to the point where we're imposing upon our fellow Americans, women in particular, our preferences, we are going down a pathway that we should have evolved out of centuries ago. So let me thank you again, witnesses, for being here today. I want to talk to you about the provision of abortion care and what state bans are really about. We know that abortion is a safe medical procedure, and yet targeted regulations on abortion providers, often called trap laws, make providing abortion care more difficult, but not any safer.
According to a 2018 report by the National Academies of Sciences, Engineering, and Medicine, abortion is safer than childbirth, colonoscopies, certain dental procedures, plastic surgery, and tonsillectomies. Madam Chair, I ask unanimous consent to put this report into the record. However, we have seen hundreds of state laws and restrictions that single out abortion care under the guise of safety that seem more focused on making access to abortion care more difficult. An American College of Obstetricians and Gynecologists, in a published committee opinion on the topic, found that government restriction on abortion results in the, quote, marginalization of abortion services for routine clinical care, end quote, and are, quote, harmful to women's health, end quote. The same National Academy study found that the greatest threat to the safety and quality of abortion are unnecessary government restrictions. So my question is to you, Dr. Robinson. Will you discuss the safety profile of abortion in relation to other routine medical procedures like colonoscopies, tonsillectomies, or plastic surgery?
Abortion care is very safe. The risk of women having a bad outcome or having a complication with an abortion is less than 1%. According to the CDC, it's less than the chances of having an adverse reaction to a penicillin shot. So abortion is already very safe, and these restrictions that are being placed do not make abortion any safer for women. It only blocks access to care.
So do you agree with the National Academy's report that found that state restrictions are more harmful to the quality and safety of abortion care than anything else?
I do agree with that.
What are some of the ways that abortion restrictions threaten the quality and safety of the care that you're able to provide?
Well, these restrictions, they push a lot of women out of the medical system altogether, where they're not able to reach a safe provider to counsel them and give them proper care. Some of them are having to access care by the best means that they know, which is sometimes just accessing the care through the internet. They would be served better sometimes by being able to have a provider locally in their area. It decreases the number of providers who are available to provide care for women, so that means that some patients will never reach a facility when they do need it.
Very well, and we've heard a lot of conversation here today, some factual, some based on opinions. It is valuable to hear the perspectives of everyone here, but at the end of the day, part of the freedom of being an American is self-determination. Self meaning every human being, not irrespective of gender. And I resent the fact that in the 21st century, this next generation is being imposed upon. They have a choice. Ladies, young ladies, you have a choice, and you have a right to exercise that choice. With that, Madam Chair, I yield back.
I thank the gentlewoman. She yields back. Let's see. We have one more member waving on to the subcommittee, and that is Ms. Schakowsky from Illinois, and I believe that will be the end of questions from members. So the gentlewoman is recognized.
I also thank our chairman for allowing me to wave onto this subcommittee. It's been very, very meaningful. I know that when I stepped out of the room, Mr. Gianforte allowed Ms. Collette to make incorrect claims about the opinions of medical professionals on the importance of abortion access. I just wanted to read a little bit about the American College of Obstetricians and Gynecologists, which is the nation's leading medical specialist for women's health and the authoritative body in the development of the standards of care for women, and not part of the abortion industry. And I am just wondering if Ms. Northrup or Dr. Robinson, can you clarify, maybe once and for all, probably not once and for all, what medical professionals have said about the legislation that we're talking about today? Dr. Northup, Ms. Northup first.
Well, what I can say is about what medical professionals have said about the type of laws that the Women's Health Protection Act would address, which is that both ACOG, as you've talked about, and the American Medical Association have taken positions against many of these laws because they're not based on medicine and they're not based on good care of patients. And I would also just point to the American Medical Association has a brief in the Supreme Court case, along with 13 other professionals, in which they are very clear when they talk about the admitting privileges law that the Supreme Court look at, it's not medically necessary. Abortion is a safe medical procedure, and nationwide they say patients are being harmed by medically unnecessary restrictions on abortion clinicians. The American Medical Association doesn't take a position on whether its members should or should not provide abortions, but they take a position on these types of regulations that are not based on science and medicine.
And Dr. Robinson, are you part of the abortion industry? Is there some such thing as the abortion industry that is pushing a skewed view of the health care that you provide?
No, I'm part of the American Medical Association, the American College of Obstetricians and Gynecologists. I am a proud abortion provider and an obstetrician gynecologist who cares very deeply for my patients.
And I'm assuming that you also provide prenatal care to women who want children and help facilitate that as well, right?
Yes, I do.
I also wanted to point out that in addition to, we have supporting this bill, the American College of Obstetricians and Gynecologists, the American College of Nurse Midwives, and the Society for Maternal Fetal Medicine. So, you know, again, I think this idea, and you had time to talk about this abortion industry, that what we're talking about and what we are trying to protect. Look, I'm a mother of 3, a grandmother of 6, and we embrace our children, and we call this choice because you, Ms. Collette, and you, Ms. Fortney, are free to organize around this issue, to promote the issue, but we are talking about women having the opportunity to choose, not to prescribe one thing or another, or to invite politicians into the room. I think that is what is so offensive. Ms. Alvarado, can you just talk about that for a minute? Or less, 41 seconds.
Absolutely. No, it's incredibly infuriating that so many women not only face these restrictions, the similar ones that I faced, but they face even greater restrictions in their home states. Abortion access is health care, and women are capable with their partners and their doctors, if they so choose, to make the decision to access this health care.
Yes. I know it must be frustrating to some. This is a pro-choice House of Representatives, and all the polling suggests this is a pro-choice nation. And I yield back.
Gentlewoman yields back. I see that our colleague from Pennsylvania has joined us. Welcome to the subcommittee, waving on. Mr. Doyle of Pennsylvania is recognized for 5 minutes of questions, and you may proceed.
Thank you very much, Madam Chair. First of all, I want to say thank you to all of our witnesses here today. I want to especially thank Ms. Alvarado for your service to our country, which includes your testimony here today. Your story is one that I really hope has resonated with my colleagues on both sides of the aisle, and I hope has made everyone on this committee think about our own history, our hopes and plans for our families, and most importantly, how we treat our neighbors. I, for one, am a co-sponsor of the Women's Health Protection Act because I believe that we need to treat our neighbors, women across America, with basic respect that allows them to make the best health care decision that is best for themselves and their families without interference of the state or federal lawmakers. So with that said, I know that I'm the last person to speak here today, and you've all answered a lot of questions. I'd just like to start by asking both Dr. Robinson and Ms. Northrup, are there any false or misleading claims that you've heard here today that you'd like a few minutes to clean up or correct the record on? Anything you'd like to add? I want to give you some time if there is.
Yes. One, the implication that women, when they come in to have an abortion procedure, that these women, that they may need additional time. I am the physician. I have the opportunity to establish a rapport with my patients. I have the insight to know those women who may need additional time. And these patients, after we counsel them, even though we have a mandatory 48-hour waiting period, there have been times when I've talked to a patient and have told her that perhaps she needs to go and take a little bit more time and come back. I don't need the state to put that restriction in place for me. I'm already doing that for my patient. So every woman that comes through the door for an abortion doesn't necessarily leave with an abortion. Sometimes they're really just coming because they need someone to talk to. And we're doing that already in our center, and we're doing it well.
Thank you. Ms. Northrup, do you want to add anything?
Yes, just to correct what's been said about the breadth of this statute. The statute is very targeted to aim at being able to provide abortion care and get abortion care free from medically unnecessary limitations. So this is only about those directed at abortion providers that are not medically necessary. And we've heard a lot about it'll overturn the Hyde Amendment. That's not the case. That you'll be forced to provide abortions. That's not the case. That it will change the standard of viability from Roe. That's not the case. It is directed at this reason that in the 21st century we're still arguing about this is that these laws are unfair attempts to close clinics, deprive women of access, and they make it unfair across the nation so that your zip code is driving whether you can access services. That is the target of this law. It's right for this moment, and urge again for the committee to recommend it's getting a floor vote.
Thank you. And finally, Ms. Alvarado, is there anything you'd like to add?
Thank you so much. I share my story here today because these restrictions don't just live in a vacuum. I'm a testament to these restrictions and how they affected my life. And I'm only grateful that I had been empowered to make the best decision for myself. And I am grateful to that 22-year-old who had the fortitude to not only face those obstacles, but pass them to make the best decision for herself. Thank you so much.
Thank you for being here today, and I want to thank the witnesses. Madam Chair, thank you so much for your indulgence, and I yield back.
The gentleman yields back, and thank you for coming. You're always welcome at this subcommittee. I now would like to once again thank all of our witnesses. Dr. Robinson, you've done an extraordinary job. I'm sorry I had to cut you off, but I'm generally very generous with time and go over, much to the frustration of members on both sides of the aisle, because every word really counts, and witnesses come here really loaded with very important information, but know that it's, I'm trying to adhere to the rules of the committee. Ms. Forney, thank you for coming and testifying. Ms. Collette, thank you. Ms. Northrup, 17 years plus lawyering. And to Ms. Alvarado, you have heard the expressions, I think, from, I believe, from both sides of the aisle, thanking you for your service to our country and for, I always say it takes courage to have courage. So thank you for yours. I would like to now submit the following statements for the record. What Mr. Duncan requested be placed in the record will be. Mr. Belarakis' request will also be placed in the record. And I am requesting unanimous consent to enter the following documents into the record. It's a very long list. A letter from Dr. Steve Weinberger, Executive Vice President and CEO Emeritus of the American College of Physicians, Dr. Barbara Levy, Clinical Professor of Obstetrics and Gynecology at George Washington University, and Deborah Ness, President of the National Partnership for Women and Families. A letter from the reproductive justice community in support of the Women's Health Protection Act. A statement from the Guttmacher Institute in support of the Women's Health Protection Act. A 2018 report from the National Academies of Sciences Engineering, and Medicine entitled The Safety and Quality of Abortion Care in the United States, a report from the National Bureau of Economic Research entitled The Economic Consequences of Being Denied an Abortion, a 2018 article from the American Journal of Public Health entitled Socioeconomic Outcomes of Women Who Receive and Women Who Are Denied Wanted Abortions in the United States, a 2017 article from the Journal of the American Medical Association entitled Women's Mental Health and Well-Being 5 Years After Receiving or Being Denied an Abortion, a 2018 article from the Journal of Medical Internet Research entitled Identifying National Availability of Abortion Care and Distance from Major U.S. Cities, Systemic Online Search, a report from the Center for Reproductive Rights entitled Roe and Intersectional Liberty Doctrine, the Supreme Court amicus brief of 11 storytellers filed in the Supreme Court case June Medical Services versus G, a 2017 report from the Center for Reproductive Rights entitled Evaluating Priorities, Measuring Women's and Children's Health and Well-Being Against Abortion Restrictions in the States, a 2019 report from the Center for Reproductive Rights entitled What If Roe Fell?, a statement from the ACLU in support of the Women's Health Protection Act, a statement from various LGBTQ groups in support of the Women's Health Protection Act, a statement from the Hope Clinic for Women in support of the Women's Health Protection Act, testimony from the National Council of Jewish Women in support of the Women's Health Protection Act, a statement from the National Family Planning and Reproductive Health Association in support of the Women's Health Protection Act, a statement from Platform in support of the Women's Health Protection Act, a statement from various reproductive justice groups in support of the Women's Health Protection Act, a letter from various independent abortion care providers in support of the Women's Health Protection Act, a letter from 53 faith-based religious and civil rights organizations in support of the Women's Health Protection Act, a statement from Representatives Chu, Frankel, and Fudge in support of the Women's Health Protection Act, a statement from Kristen Clark, President and Executive Director of the Lawyers Committee for Civil Rights Under the Law in support of the Women's Health Protection Act, a statement from Tony Van Pelt, President of the National Organization for Women in support of the Women's Health Protection Act, a letter from Moms Rising in support of the Women's Health Protection Act, testimony from Martin H. Wolf, Director of Sustainability and Authenticity for Seventh Generation, Inc., in support of the Women's Health Protection Act, a letter from 14 state attorneys general and the Attorney General from the District of Columbia in support of the Women's Health Protection Act, a letter from the Freedom from Religion Foundation in support of the Women's Health Protection Act, a letter from the Women of Reform Judaism and the Religious Action Center of Reform Judaism in support of the Women's Health Protection Act, a letter from the Planned Parenthood Federation of America and the Planned Parenthood Action Fund in support of the Women's Health Protection Act, testimony from the National Network of Abortion Funds in support of the Women's Health Protection Act, a letter from S. Nadia Hussein, Maternal Justice Campaign Director for Moms Rising in support of the Women's Health Protection Act, a letter from Vanita Gupta, President and CEO of the Leadership Conference on Civil and Human Rights in support of the Women's Health Protection Act, a letter from Catholics for Choice in support of the Women's Health Protection Act, a letter from NARAL, Pro-Choice America, in support of the Women's Health Protection Act, testimony from Leila Alba-Fazli, Director of Federal Reproductive Rights at the National Women's Law Center, in support of the Women's Health Protection Act, a statement from the American College of Obstetricians and Gynecologists in support of the Women's Health Protection Act, a 2019 article from the Journal of Obstetrics and Gynecology entitled Consensus Guidelines for Facilities Performing Outpatient Procedures, Evidence over Ideology, a letter from 5 law professors in support of the Women's Health Protection Act, a compilation of 114 abortion stories. I believe I mentioned this right off the top, submitted by Representative Bilirakis, an abortion story from Elizabeth Gillette, an abortion story from Pam Thompson, an abortion story from Terry Nordone, a press release from the Susan B. Anthony list dated February 12th, 2020, a letter from March from Life Action opposing the Women's Health Protection Act, a statement from Americans United for Life opposing the Women's Health Protection Act, the Supreme Court amicus brief of Priests for Life and Rachel's Vineyard, followed in the Supreme Court case June Medical Services versus G, an article by Thomas M. Mesner, JD, entitled The Women's Health Protection Act of 2019, 10 Things You Need to Know About H.R. 2917. So without objection, so ordered. And
Additional unanimous consent request.
go ahead, you're recognized.
You've covered most of them, but also a unanimous consent request to add a legal analysis by the Charlotte Lozier Institute, and just to be certain on the Susan B. Anthony list, press release entitled House Democrats Hold Hearing Promoting Abortion on Demand.
So ordered. So I'd like to remind members, there are all of, 3 of us left here, that pursuant to committee rules, we each have 10 business days to submit additional questions for the record. I certainly plan to do so, to be answered by the witnesses or witness who has appeared. And I ask that each one of the witnesses respond promptly to any questions that are submitted to you that you may receive from a member or more than one member. So thank you again to each one of you. We have not taken a break. You've been at the table as long as I have for almost, almost 4 hours. And thank you to everyone that is in attendance here today. I think everyone has really comported themselves with a great deal of dignity, with professionalism, and as chair of the subcommittee, I wanted to recognize all of you for doing that and thanking you. With that, the subcommittee is adjourned.